Associate Professor Dr. Siti Norshina Muhammad Zain, President of the Malaysian Society of Parasitology and Tropical Medicine, MSPTM, Dr. Rabindra Abeyasinghe, Coordinator, Malaria and Other Vector-Borne and Parasitic Diseases Unit, Division of Communicable Diseases, WHO Western Pacific Region, Manila, Philippines. Associate Professor Dr. Pratap Singhasivon, Dean, Faculty of Medicine, Mahidol University, Thailand. Professor Datuk Dr. Lokman Hakim Sulaiman, Director, Institute for Research, Development and Innovation, IMU. Today's guest of honor, Emeritus Professor Dr. Mak Joon, distinguished guests, ladies and gentlemen. We are very pleased to welcome all of you to the MSPTM Mid-Year Seminar themed Relevance and Importance of Tropical Medicine, organized by the International Medical University, IMU, in collaboration with the MSPTM, in honor of Prof. Mark as recognition of his immense contributions to tropical medicine and public health. To start off, I would like to invite Professor Peter Pook, Deputy Vice-Chancellor Academic of IMU, to deliver the welcome address.
A very good morning to Associate Professor Dr. Siti Norshina Muhammad Zain, Dr. Rabindra Abeyasinghe, Associate Professor Dr. Pratap Singhasivon, Professor Dr. Lokman Hakim, and a very special guest of honor, Emeritus Professor Mak Joon, and Mrs. Mark also amongst the audience. We like to call her Dr. Chung in recognition of her own status. Distinguished guests, ladies and gentlemen, this is indeed a very special seminar for Prof. Mark, and especially organized in honor of his immense contribution to tropical medicine and public health. For those of you who may not know of this giant's history, Professor Mark obtained his medical degree from the National University of Singapore in 1967. After graduation, he served in various hospitals under the Ministry of Health Malaysia for 5 years before joining the Institute for Medical Research, or better known as IMR, in 1972. During his stay with the IMR, Professor Mark headed the Malaria and Filariasis Division and the Biotechnology Division before his appointment as director in 1995. After his retirement from IMR, Professor Mark joined the Faculty of Medicine and Health Sciences in University Putra, Malaysia in 1997, where he served for 3 years as Professor of Tropical Medicine. And in this juncture, I personally met Professor Mark in UPM. And not knowing of his track record, this greenhorn came back from UK and did not know he had the privilege and honor to meet the giant of tropical medicine there, together with Professor C.P. Ramachandran, whom I've not seen for years, and he's here. And also, to my surprise, I saw Prof. Mark's PhD student also was there, Nga Ibrahim there, sitting there. Prof. Mark, with great reluctance from our part, retired from the IMU on 15 January this year. Presently, Prof. Mark is also Fellow of the Academy of Sciences Malaysia and a Fellow of the Academy of Medicine Malaysia. Whilst Prof. Mark was in IMU, he served as Professor of Medical Parasitology and later as Dean of the School of Postgraduate Studies. He was also appointed as Vice President Research in 2011, and later, before his retirement, he was appointed as our Pro Vice Chancellor Research in 2016. He was also appointed as Director of the Institute for Research, Development and Innovation IRDI in 2012. And I'm pleased to report that now his very own protege has taken over this role, and that is none other than Professor Datuk Lokman. Professor Mark's main research interests have been in tropical medicine, bioactive molecules, and infectious diseases. Without a doubt, he's a globally recognized expert in filariasis and malaria, and was appointed as a consultant by the World Health Organization in 17 countries. For you researchers, don't hold your breath. He's published over 360 scientific journals, scientific papers in refereed journals, and was the founding editor of the MPSTM's journal, Tropical Biomedicine, which is the first biomedical ISI journal in Malaysia. He has successfully supervised 13 PhD and 13 MSc students, lucky 13s, and has co-authored an atlas of medically important parasites with his wife, Dr. Chun Mui Fa. This is a text reference very well used and popular by undergraduate and postgraduate students, having 5,000 copies currently sold worldwide. For his significant contributions to fundamental and applied research in parasitology and tropical medicine, Professor Mark was the joint recipient of the National Science Award, or the Anugerah Science Nagara, in 1985. He was also the recipient of the prestigious Santoshan Gold Medal in 1989 and the winner of the prestigious Merdeka Award for Outstanding Scholastic Achievement in 2011. At the IMU convocation on 12th of September 2015, Professor Mark received an honorary doctorate of science as recognition of his immense contribution in promoting research at the university. Under his dedicated stewardship, the university has made significant progress in research, as evidenced by increases in the number of peer-reviewed publications, external research funding, and the number of postgraduate research students here. Those of you may not know, when Prof. Mark joined in IMU being a private institution, were not eligible to apply for research funding from the government. It was Prof. Mark who wrote his seminal paper to the government that opened private institutions to be eligible to apply for research grant. For his immense contributions in both teaching and research, Professor Mark has been appointed just last weekend as IMU's first emeritus professor at our recent convocation. Whilst Professor Mark may be devoted to his work and research, he is an extremely loving husband and father, and both Prof. Mark and his wife, Dr. Chung, have 3 wonderful children, 2 boys, Yu Meng and Yu Nam, and a girl, Yuet Mei, and 5 grandchildren. We often tease him that the apple of his eye is his daughter, Yuet Mei. Prof. Mark has many hobbies, which include jungle trekking, hiking, gardening, and reading, especially poems and classics. So, ladies and gentlemen, the focus of today's seminar is a topic which I'm very sure is very close to Professor Mark's heart: tropical medicine and public health. We have 3 very eminent speakers who will be deliberating on the past, current, and future developments in tropical medicine in Malaysia and in this region. This will be followed by a panel discussion, and in addition, we have a poster competition for undergraduate and postgraduate students. With that, I would like to take this opportunity to welcome our foreign participants. I understand there are visitors and colleagues from Thailand and Philippines. I wish you all a very fruitful and engaging seminar. Thank you very much.
Thank you, Prof. Peter. A quick announcement. Details for access to Wi-Fi and the online abstract book are available behind the name tags provided. Throughout the seminar, if you have any questions, you may post them via the online link or QR code on the screen. The questions will be addressed during the panel discussion in the afternoon. We will now begin the first plenary session, which will be chaired by Professor Chu Wan Loy, Dean, School of Postgraduate Studies, IMU.
Thank you. Thank you for the introduction, and good morning, ladies and gentlemen. We are very pleased indeed to start off today's seminar with our first plenary paper by Associate Professor Dr. Pratap Singhasivon. Associate Professor Dr. Singhasivon is currently the Dean of the Faculty of Tropical Medicine, Mahidol University, Thailand, and Director of the Simeo TropMed Thailand, and Secretary General and Coordinator of the Simeo TropMed Network. Dr. Singhasivon was awarded his medical degree from the Kasturba Medical College, India, before receiving his postgraduate diploma in tropical medicine and hygiene at the Faculty of Tropical Medicine, Mahidol University. He received his Doctor of Public Health degree from the University of Michigan, USA. So Dr. Singhasivon is a long-standing advisor to the WHO and a strong supporter of WHO activities addressing health problems in Southeast Asia. He also plays an integral role in Thai national malaria policy and contributes to more than 190 publications. So in 2018, Dr. Singhasivon received the National Award for Outstanding Preventive Medicine, Physicians of the Preventive Medicine Association of Thailand. So without further ado, let us welcome Dr. Singhasivon. Thank you.
Already loaded, maybe. Yeah, that is.
So which one of the slide?
Good morning, ladies and gentlemen. Professor Mak Chunwa, Professor Ramachandran, Professor Peter Puk, Professor Chu Wan Loy, Professor Lokman, and ladies and gentlemen, I'm very honored to be here today to also pay tribute to Professor Mak Chunwa because of his greatest contribution to the regional, our region in propagating and also in contribution to the tropical medicine. And I'm very honored to be one of the speakers today. And as you know that filariasis, in his expertise with Professor Ramachandran, who are sitting here now, you should be glad that many countries in Southeast Asia has also now declaring filariasis free. For example, Thailand last year already submitted the dossier, okay, for filariasis elimination. And I think that this is a very good opportunity. As you can see here, today I will be speaking about the past. We have seen that in the past 52 years, if you look back in the past 52 years or 60 years in the past, and if you look at our region, we say tropical medicine. When we say tropics, we imagine that it is from the line from the equator. If you go up 23.5 degree north okay, the tropic, okay, of Cancer. And if you look down 23.5 degrees south, that is the Tropic of Capricorn. So between these two regions, these two lines, 60 years ago, you will see that there are 140 countries around this area. And also we have about 40% of the world population at that particular time. What happened during that time? It was not like today. At that time, you will see that we are suffering from, we call first generation diseases, that is the communicable diseases that is related to vaccine preventable diseases of today. We have waterborne, we have foodborne, we have diseases related to environmental hygiene and other things. So it was devastated at that time, whether it is vector-borne diseases at that time. So what happened at that particular time, that when in 1966, okay, in 1966, there is a kind of the people of the region, that is Southeast Asia, coming together. That time we call the ASEAN countries, coming together and say that we have to do something about education. It started with education. That's why Simeo was born. Simeo was born at that time because of the visionary kind of things about the regional leaders. Our regional leaders are, at that time, we have to say that they are very, very good at that time. So therefore, they established in 1965, okay, Southeast Asia Ministers of Education's organization in order to upgrade. Because we see that diseases are related to poverty, we have to boost up the education. How to make people in our region. Now, as you know, that in Southeast Asia, we have now around 600 million people. Okay, and at that time we still not integrated. So we started with educations, and now today, okay, at that time we also have almost 10 member countries. Today we have 11. So all ASEAN we have 10, but CMEO we have 11. And CMEO established before ASEAN, okay, as the all the Minister of Educations come together. Today, we also have associate members and also affiliate members. Our associate members of CMEO, we have from Australia, Canada, New Zealand, Spain, France, okay, and also other countries. Affiliated members are also about 8 or 9 members. So CMEO now become very strong, okay, and also very cohesive. And this is the organization that have a vision mainly in educations and capacity building, okay, in many areas, which I'm going to mention to you, okay, in order to lead to the better quality of life in Southeast Asia. So many of you might not be heard of CMEO, but today I think you will be knowing that. So the mission of CMEO, okay, is through we have a networks, okay, of partnership, and also in also promotion of sustainable human resource development. So human resource development is the main, and have been asked today to talk about the tropical medicine, okay, human resource development. So CMEO as a whole, okay, it is the as you can see here, they have a meeting of policy making body, that is the Minister of Education of each country. And if you look at CMEO, CMEO is not tropical medicine. CMEO is centers. Now we have 22 centers. There will be another 2 or 3 added from other countries. It will be 25 centers. So these 25 centers are specialized centers that are the centers in science, education, and also culture. So for example, Malaysia have 3 CMEO centers. For example, we have here centers for tropical medicine, regional center for tropical medicine is the Institute of Medical Research, IMR. And also now Simeo also have very good center for mathematics, Rexam, in Penang. And also we have a Simeo Sen. Okay, Simeo Sen is means for specialized need, okay, special need for children, means that for children or who have a specialized need. So that is center in Malacca. So for example, this is centers that are really contributing, and other centers, for example, if you look at in Indonesia, in Philippines, you have a Innotech, we have a Philippine Regional Center for Agriculture, you have a higher educations, other countries. So this is a specialized centers and form a network. We are one family. And if you come to Simeo TropMed, okay, Simeo TropMed is special, little bit that we have 3 centers. In the past used to be 4. So now we have a center, regional center of tropical medicine in Mahidol University, Faculty of Tropical Medicine. We have IMR. We have in Philippines, the College of Public Health. These centers, we have a network and we have a coordinating office in Bangkok. So we have been working for the past, Simeo Tropical Medicine Network has been working for the past 52 years. Okay, so it is the longest network in the world. Okay, it's very difficult to have any network between tropical medicine for so long. And then it is contributed like persons who are sitting here today. Okay, as you can see here, Professor Mark, okay, Professor Ramachandran, Professor Jekatesan, okay, and then we have a founder, one of the founder, Professor Chamlong from Thailand. We have several well-known professors in the region from the Philippines, from Indonesia. We'll see that. So this is something that I think, today I'm going to also discussing about the Simeo TropMed and Public Health Network contributions in human resource development. So also our centers is not like other centers. The Simeo TropMed network is different from Rexam, from Raihead, okay, from Innotech. Okay, we have so many centers. So that is they are specialized centers. These centers are standing by their own. But when we are talking about the Simeo TropMed network, it is just putting another hat on the existing center which is already running by its own. For example, if you look at the IMR, it is the Ministry of Public Health branch of research, and then they just put another hat, okay, on top to say to become the regional center for Simeo. So the funding, the grant, it is through the government system already, but they are also working at the same time, contributing to the regional training, okay, for tropical medicine. So therefore, it is similarly for Thailand, for clinical tropical medicine, and also for the Philippines. So these are the 3 centers. It is the international also development. And if you already know about the mission, mainly is on the capacity of the individuals. So if we read, okay, and then we can ask Professor Ramachandran and Professor Mark, looking back into our 50 years ago, what has been there. So the ministers of education at that time, that is a project on Simeo TropMed network project. It started with project. What they think? They think that the health is very important for education. If you don't have a good health, education will be very difficult to occur. So therefore, that's why they have established this center in order to promote health also at the same time with the educations. So you will see that the philosophy at that time, you have many people contributing from, like for example, in this example, you'll see that His Excellency Sarino from Indonesia has also thinking that working together and collaborations among the ASEAN countries would be very important in order to move forward. Okay, So these are, I'm just trying to pay tribute and also to tell you that because these are the visionary leader, and that leadership make possible for our collaboration to go on in our region. And if you look at His Excellency Tengku Abdul Rahman also have mentioned that, okay, to collaborate and share the experiences gained by health and medical personnel of the countries in this region for mutual benefit. So this is something that they have been discussing also in the past. And if you look at from the Philippines, collaboration. So we look at the collaboration, cooperations as a very important element in moving forward for our region like the ASEAN today. But the CMEO is not kind of through that mechanism, okay, like ASEAN, that so we are moving. And also, let's say His Excellency Mom Luang Pin Malakun of Thailand also have mentioned very clearly that we live in the tropics. Tropical diseases are our problems. Who will solve our problems if we are not solving our problems? As I could date back, okay, several years ago, when why Faculty of Tropical Medicine was established. Because Professor Chamlong Harinasut, our founder of Faculty of Tropical Medicine, he went to study his PhD from Liverpool School of Tropical Medicine. Then one day he realizes that when he went to study tropical medicine there are not a single case of tropical clinical cases for him to see. But everybody has to come to London School and to Liverpool School of Tropical Medicine. Then he realized that he has to start something in Thailand. And one day was very lucky for him and lucky for Mahidol University at that time also, that the Prime Minister, okay, Sarit Thanarat, he had dysentery. So he was called, Professor Chamlong and Dr. Bukit Viranuwat, the Dean of Sirirat, he was the Dean of Sirirat, not at that time, but afterwards, was called to treat him because they know that they are the expert in tropical medicine. And then he could treat the Prime Minister, who was a military dictator at that time. He was cured in 3 days. And then he was very happy. So when he was very happy, what happened? He asked Professor Chamlong, would you like to become a health minister? Because that time, when you become very powerful, you can appoint anybody at any time. And if he have said yes, we would not have Faculty of Tropical Medicine. Okay, if I were him, I don't know what would I say. But anyway, he said, no, I want a school. So that's when he said that, no, I want a school. Then he said, what kind of school? So in the location of Faculty of Tropical Medicine today is a military area. It's a military barracks. You see the military hospital in front. So within 2 years, they were evacuated. And the School of Tropical Medicine, Faculty of Tropical Medicine was established. So that's why we were born, okay, at that, from that time on, because of his vision, because he did not think that become the minister is important than become a professor, okay, or contribute to the country. And that's why we say that this is, so therefore you look at the CMEO, so CMEO TropMed look like that we have a governing board, and then CMEO TropMed Network Office, and then we coordinate, and then still we are working very well. And you see the governing board are representing all the people from Southeast Asian countries. We have partners coming with us, and then we have the meeting, we have discussing together every year. This year will be in Myanmar, okay? So this is the very quick kind of the to see that how the organization, I would like to promote and then tell you about that what is the CMEO has been doing, and then we have celebrated 50 years of CMEO 2 years ago. A lot of people came from the region, and as you can see here that our the main thing is the human resource development, Okay, research is also very important because we use research to teach. Our centers always doing research to teach and also to provide that research finding, to providing the new treatment guidelines, preventive guidelines, and also doing so many issues on that one, and also educations and that one. So it comes to today topic that semiotropic network impact on HRD in the region. Okay, so let's see. We know that semio, okay, before I'm going to go into the academic programs and then telling you more about semio, I would like to say that now the semio organizations as a whole has 7 priorities. All the ministers of educations of the semio countries, like it's the ASEAN, we can say, plus Timor-Leste, have 7 priorities. Priorities number 1 of the semio, not semiotropic network per se, it is the achieving the universal early childhood education, care and education. You see, now the ministers are thinking that the education is going to be occurring in our, for the people of Southeast Asia. We have to start very early. Okay, you have to start very early on creative and critical thinking skills through inquiry-based teaching and learning from the very early childhood. So that is the first priority of the semio. So therefore, the early childhood care is related to us also. Whether it's education about health, even now our faculty of dentistry also now starting the early childhood dentistry. Even before dentition, even before you see the teeth coming out, they already have the early childhood care for dentition already. So therefore, that is the first one I would like to tell you. The second one is about addressing barriers to inclusion. It means that in our region, for education, we should not have any barriers. We should include everybody. That is why Malaysia is a very good example of trying to put on the, like semiosen, is for special needs. Sometime in our school, only the good children will be visible for the teachers. Teacher will see only the student that who score very good marks. Okay, but those who are not there will not be visible. So therefore, for especially very talented or disabled. The third one is the resiliency in the face of emergencies. Now our region is full of disasters, of so many things, okay, in terms of economic, political, natural disaster. We have to be resilient, okay, it should be resuming the original position very quick. Also promoting technical, vocational education training, okay, that's going to be priorities. And then also revitalizing our teacher educations. That is going to be important, and also harmonizing higher education and research. So this is going to be very related to our university, how to harmonize. Now we have an ASEAN integration. So the doctors who are educated in this hospital, in this university, can they work in Singapore? Would they be able to work in Thailand, work in Malaysia? We have semiotropic network has done this kind of possibilities to see that how this ASEAN integrations are going to have effect on this, and also adopting the 21st century curriculum. That is going to be the 7 priorities. So you can see here that human resource development, we have through research, study visit, regional conference, internship, attachment programs, special programs, all this we are doing. So in our region, can you raise the hand also if my time is up? Because I see it's 45 minutes, so I keep on putting so many things. So therefore, through our network, we have 19 academic programs offered by 3 TopMed network regional centers. So we have 5 diploma programs. For example, we have diploma in tropical medicine, okay, and hygiene. We have diploma in applied parasitology and entomology, and also in immunology and microbiology, okay, offered by IMR, and also tropical medicines. And we have also diplomas in health informatics. Also now we have, and 11 master's programs, okay, in various areas, from public health to tropical medicine to school health to also in occupational health and other things, and also 3 PhDs program in the 3 centers. So there are scholarships has been reduced because of the funding, but still many students are there. So we have about 20 to now about 35. It's more than this. So we are trying to use through the international organization to support more. And also we have 700 students per year enrolled in these programs. Okay, so these are some of the contributions in training through our centers. And so far, if you look at so far, these are some of the PhDs, masters students, and also diplomas students have been trained. Okay, so these are some of the impact on the region, as you can see. So some of the things that we should be proud of, that this is contributions to our region. Myanmar, because in the past they could not send a lot because of the limitations of the country to send, because they need 3-4 months preparation to be above. So if you look at the distributions, you will see that masters is about 45%, almost 45% of all the students trained in the master degree programs. And also semiotropic scholars, you will see that our semiotropic scholars are now distributed and also going all around the world. You see, I am one of the semio scholars, and also one of the WHO TDR also scholars. And when I got this scholarship, Professor Ramachandran was working also at the TDR at that particular time. And then during that time, they are trying to have an institution strengthening program for the semio centers. So Faculty of Tropical Medicine was very lucky. More than 10 people have been sent for PhDs, okay, through WHO TDR scholarships, that one. So as you can see here that these are our alumni are excellent, going everywhere. So we have also short courses in health and health-related professional, health and health-related institutions, academic institutions. Okay, so short training course every year. Okay, there are about 50 short training courses. On average, there are about 2,500 average total participants per year, and also 35 average fellowships that's related to this one. And tropical diseases short course is throughout the year on malaria, on dengue, on HIV, as you can see, where the next speakers will be discussing about tropical diseases, also related to the non-communicable diseases. Also, we have short courses. We have a nutrition, also it's very important aspects through our centers. And also, we also have several forum and flora here on emerging issues. As you say that our public health scenario has changed. Our world is not like before. So we have on what will be the effect of climate change on vector-borne diseases. Is there any evidence based to say that they will change or not? We know that in our laboratory that when the temperature increases, we see that increased feeding rate among the mosquitoes. They will bite more frequently. The extrinsic incubation period for for parasite, for virus in the vector will be shortened, okay, and also the development stages of the mosquito will be also shortened. We know all this, but would it have the impact on epidemiological transmissions, water health, One Health? Now I think the One Health concept is going to be very important because that should be the integration between the human, animal, environmental. We have to have the intersectoral, multidisciplinary, and also interdisciplinary approach, because now not only one organization can solve the issues. So it were varieties of issues, spatial concerns, and we always update on this. And also our centers are involved in a lot of research. Okay, randomized control trial on new interventions. For example, you will see that dengue vaccine, after the from the Sanofi vaccine, now we have Takeda, and also NIH vaccine is being trialed in our centers in Thailand and also in some of the other centers. So these are all the research centers that are doing. So, and also the management related issues, training on leadership soft skills. We want our teachers, our lecturers to understand about the soft skills. Okay, we need to have put the soft skills, not only the technical skill, hard skills into the students, leadership, communication, critical thinking, and also the teamwork and other skills that is needed, okay, for our students to work anywhere in the world, and also can also compete and communicate to the other students. And also these are some of the activities. I'll go a little bit fast. As you already know, research activities. Also we are doing a lot. And from our 3 centers, we published, in fact, this year, this is not the correct number, this year Faculty of Tropical Medicine alone published 325 research papers, and 75% in the Q1, means that in the first quartile of the journals top. So I think that now we have more than 450, at least 450 to 500 research papers published from the 3 centers. And also our research area are many of the research from IMR are translational and also become entrepreneurial, academic entrepreneurship. It means that it also linking with the commercial, public, private sectors, so it become commercialized. So that is important. So university now learning from research, not only publication, but how it's going to influence policy and practice, and also how it's going to make income by commercializing those diagnostic kits. And for example, IMR is doing extremely well, okay, commercialized on the maggots, okay, and the wound sealing, and then also using the insecticide, putting in the paint, okay. So all these are the things that also working with the private sectors with the diagnostic test also. Okay, these are some of the research projects that has been also awarded, have received the prize, and so many things, as you know. And the most important thing is that we also have the journal, that is a Southeast Asian Journal of Tropical Medicine and Public Health, okay, and also published spatial issues of so many things that related to the health issues of Southeast Asia, okay. And I think the HR is the future needs in our region, and I think our centers has significantly contributed to the capacity building and human resource development in the past 52 years. And there are still new challenges that we have to be concerned, emerging diseases. In the past 20 years, we have more than 50 diseases that have been newly emerged. We have going to have issues on human, okay, animal transmission, wildlife related. Recent outbreak of Nipah virus in Kerala in India. You will see that the mode of transmission is different from Nipah virus transmission in Malaysia. Okay, that is related. Like in Bangladesh, it is the palm sap related, and then it's coming from the fruit bat. And then suddenly it's jumped from West Bengal to Kerala. And it's very lucky that the outbreak has stopped. Out of 17, but 19 people reported, 17 died, which is have a very high case fatality rate compared to Malaysia. Malaysia case fatality rate is not more than 40%. okay, 30 something. So therefore, this is the issue that all of us in the region will be preparing. So these are some of the challenges, okay. We need new set of skills of health and health related professionals. And as you can see that we will be needing this for the future, okay. And that is the top med centers. Our centers are doing all these kinds of things. We are collaborating with all international partners. So therefore, this is going to be my last slide. And just to say that we need for the sustainable health development, and we are moving into the SDG in the 2030. Okay, one of that is the human resource development capacity building. We have to strengthen tropical medicine capability, okay, for our region. And then now we should be very glad that many diseases have been eliminated, and then many still more will be eradicated. But it's not stopping there, because we're going to face with new threats and new emerging issues. We have to be adapting ourselves all the time, transform and adapting to the new challenges. Thank you very much for your attention.
Thank you very much, Dr. Pratap, for the excellent presentation. So are there questions from the floor? Any questions from the floor? Any? Yes. Microphone, please. So there's.
Thank you, Mr. Chairman. Well, firstly, I would like to congratulate Professor Pratap for his excellent presentation. Takes us back 52 years. It's a long time in a human life. But nevertheless, he has taken over from Professor Chamlong, as he said earlier in his speech. And we have come a long way. And one of the reasons for the success of SemioTropMed is because we are not, I repeat again, we are not a political organization. We are a scientific organization, and that made all the difference. We have many ASEAN meetings held, but they're all political, and when politics mix with science, somehow it doesn't work. But he and others in SemioTropMed has kept away from local politics or regional politics, and hence I would contribute the success of SemioTropMed purely because it was a scientific organization. Having said that, I think you have done a wonderful job from Professor Chamlong's days, when I used to visit the faculty so often that time. Nevertheless, one thing I want to ask you is, perhaps you mentioned in your presentation about number of topics, but one of the new topics that is coming up every now and then, which you mentioned, like Nipah virus, zoonotic infections, and zoonotic infections under the headline of One Health. One Health has become an important issue. We had a meeting a few months ago, I think last year, when Padma organized it under the veterinary public health. We had a meeting here, and we discussed at length the issues related to One Health. And I think Nipah virus is just an example, but there are so many other zoonotic infections that is coming up. And perhaps, I don't know how we're going to tackle that, because as long as humans are working closely in the environment with animals, we are going to get new infections coming up. So once again, thank you very much, Professor Pratap, for the excellent presentation.
Do I have to answer this one? No, I'm just giving you the idea that now One Health has reached another level already in many of our countries. Recently, as you can see, in the past 5 years, there has been a support. We have a group we call the Southeast Asia One Health University Network. Okay, this network is supported by, in the first 5 years, has been supported by USAID. And we have 4 countries. All the, now there are more than, I think, 60 universities in Southeast Asia. For example, we have a university in Vietnam. So they have in Vietnam, Thailand, Malaysia, and Indonesia. So in Vietnam, for example, they have a kind of the country One Health University network. They call VOHUN. So Vietnam One Health University Network. Malaysia is MIHUN. Okay. So MyHun, not MIHUN. Okay. MyHun. So Malaysia One Health University Network. Thailand is TOHUN. Okay. And then Indonesia is INDOHUN. So if you look at, in Mahidol University alone, we included, okay, more than 20 faculties, okay. And now we are just trying to kind of develop the core competencies, courses, and then also looking at the teaching method, how to work together. For example, it's very difficult for the medical doctors to work with veterinarian. Now it's easier, but not in the past. In the past, medical doctors are superior. They have a superiority complex. They don't talk to social scientists. They don't talk to anthropologists. They think that the medical doctors know everything. Okay? But now it's not. Now they realized after the SARS, they know that public health is very important. It's not the curative aspect, preventive aspect. And then you need to talk to so many group, veterinarian, wildlife people, and also the educators. Everybody, rabies is not the issue of medical doctor. Rabies, everyone involved, even the media, even the how to put the educations. So I think this is going to be the things that semiotropic is moving towards this area very, very intensively through the networks and also to our own work. Okay, and then we already put One Health integrate into the courses, regular courses that we are putting already. Thank you very much.
Thank you very much to Dr. Pratap. Okay, so moving on, we have our second plenary paper, which will be delivered by Dr. Rabindra Abeyasinghe, who is currently the acting director of the Communicable Diseases and coordinator of the Malaria and other vector-borne and parasitic diseases unit at the regional office of the WHO for the Western Pacific base in Manila, Philippines. So Dr. Rabindra has served earlier as a regional entomologist, Western Pacific region, and prior to that as a malaria technical officer in the WHO country office, Papua New Guinea. Prior to joining WHO in 2011, he was the director of the Anti-Malaria Campaign, Ministry of Healthcare and Nutrition, Sri Lanka. So Dr. Rabi is a medical doctor by training, specializing in public health from the University of Colombo, Sri Lanka, with special interest in control of vector-borne disease. Okay, so obtained his MSc in biology and control of disease vectors from London School of Hygiene and Tropical Medicine and the Diploma in Tropical Medicine and Hygiene from Royal College of Physicians, London. So he's also the past president of College Community Physicians of Sri Lanka for 2010 to 2011. So without further ado, let's welcome Dr. Rabindra Abeyasinghe.
Thank you, Professor Chuan Lai. It's indeed a privilege and a pleasure for me to be here. My thanks go out to Professor Siti Nurshina Binti Zun Muhammad and the Malaysian Society of Parasitology for inviting me, and also my long-term friend, Professor Datuk Lokman, from previously the Ministry of Health, but now in academia as director of the Institute of Research at the IMU. He was actually responsible for introducing me to Professor Mark, and I listened to Professor Mark, and I feel like a Lilliputian. But it is indeed a privilege for me to be here and to talk to you about tropical medicine in the Western Pacific region. Okay, so I'll try to quickly go over the current situation, the diversity of tropical diseases, what we have achieved as a region, and also look towards the future very briefly. Where are we as a society today? Between the in the tropical zone, we have been achieving significant progress, as Professor Pratap indicated, not only on the academic front, but also on the socio-economic front. And today we have a diversity of communities living in plush urban environments, a mixture of urban environments where we still have immense challenges, and we still have a significant proportion of our people living in rural areas. And the existing tropical conditions, global warming, and other factors, as Professor Pratap mentioned, continue to contribute to the prevalence of tropical diseases in our countries. And I think the world of parasitology and tropical diseases is not likely to disappear soon. We still have a long way to go and a long unfinished agenda. To set the scene, I just wanted to present to you what we spend on health. And if you see, we have a diversity of ranges from 19.7% to very small GDPs being spent on health across our region. The WHO's Western Pacific region includes 37 member states and territories and approximately 1.9 billion people who are largely at risk of various tropical diseases. Now, Pratap was largely talking about the Siamo region, but the Western Pacific region also includes the Pacific Islands. And so I'm going to talk about the Pacific Islands also somewhat. The key issue is that if you look at developed countries, they seem to spend much more on health. Japan's GDP on health is about 10%, Australia nearly 10%, but many of the others are low. Malaysia has about 4.4% of their GDP on health. So there's way to go still. And when I start talking of the tropical diseases, you'll realize that where the spending is inadequate, the challenges are still remaining. And when I say spending on health, we also need to have a holistic view that it's not just on service delivery, but it's on capacity building, training of people, equipping them with the necessary access to services and commodities. All of that needs to be addressed. So I'll start with malaria because, as you heard, I have a special affinity to Sri Lanka, malaria, and I am Sri Lankan, and I used to head the malaria program. We now have eliminated malaria there. And so looking at the Western Pacific region, we have nearly 500,000 cases still being reported to WHO. And we are doing a good job with getting the deaths down, but still there is a huge challenge. But I must say we have made significant progress on the malaria front. But still in some places, among our 10 endemic countries, malaria is a huge challenge. If you look at the distribution, 90% of the regional malaria burden comes out of 3 countries, Papua New Guinea, Solomon Islands, and Cambodia. Everywhere else we've made good progress, including here in Malaysia, where if we look at, we did an expert consultation last year looking at trying to identify the challenge of now lazy malaria, and some of you in the audience here joined us at that meeting in Sabah. So what the WHO's consensus now is that knowledge malaria still remains a zoonotic malaria. It's not a human malaria. And so if you look at the human malarias, Malaysia has made very significant progress. And again, if you look at the deaths due to malaria that were reported last year, 3 countries contribute about 90% of our deaths. So we are making good progress elsewhere, but in some places we still have challenges on the malaria front. I now move to TB, and TB remains a huge problem for us. Not just TB, but also the emergence of multi-drug resistant TB. It's causing increasing challenges because managing multi-drug resistant TB is extremely costly. Now, we have about 1.8 million incident TB cases reported, and the speed of reduction is not enough. So it still is a challenge for us. Although it's only 100,000 deaths that are attributed to TB regionally, it's probably much more. But the challenge of actually providing effective treatment and ensuring treatment compliance, even with the new drugs, remains a significant challenge in TB. Now, if we break this down into countries, we have 5 high-burden countries: Cambodia, China, PNG, Philippines, and Vietnam, which contribute over 93% of the burden in the region. And if I add another 3 countries there, that is Japan, Malaysia, and Korea, it becomes 98% of the regional burden. And if you look at the numbers, the incident rates, Malaysia is in the middle, 51 to 100, right? So we have still remaining a big challenge here in Malaysia on TB. If we move that into how do we address this, because we're trying to achieve the end TB goal, and we are having a very high level UN General Assembly meeting later this year addressing the challenge of TB, because we're recognizing that we need to do something radically quickly about TB. But in this region, it still remains a big challenge. And not only a challenge from a health systems perspective, but also a social perspective, because the costs are such that people affected by TB are affected by the catastrophic costs, and we drive them into poverty. And that leads to poor compliance with treatments, and that fuels multi-drug resistance. So we have a vicious cycle there which we need to address if we want to progress the TB agenda. I move on to HIV. More than 90% of the HIV burden in the region, or more than 1.5 million people living with HIV, are found in 5 countries of the region. Are we doing well? The rate of growth of new HIV infections, new people infected with HIV, again, we have big challenges. But this is relative to population, right? So we have a challenge, and we're now seeing resistance to antiretrovirals, a new emerging challenge on HIV. How do we deal with it? Now I'm going to cover a range of diseases, and so I'm going to move quickly, because if I don't talk enough about lymphatic filariasis, I wouldn't be paying tribute to Professor Mack and Dr. CP, Professor CP here. So hepatitis B is now an emerging challenge for us. As you can see, we are one of the areas that has the highest proportion of cases. Together with the African region, we contribute nearly 68% of the global burden. Hep B, right? We're doing a good thing because we have a vaccine here, which is relatively safe and effective. And so we're reducing the infection among children. Actually, we are now, I think, less than 1% in the region. So we're progressing there. What's good is also we are making progress on the Hep C agenda. Hepatitis C, again, is a big issue in the Western Pacific region. We have about 71 million people infected across the world, 1.75 million new infections, and it's again a healthcare issue, unsafe healthcare injections. What's the good news on the Hep C side is that we have now effective treatment. Increasingly, we are looking at government supporting the treatments by reducing the cost. And more countries are signing up to support the expansion of Hep C treatments. And so we are optimistic that things may change in the future. I will now move to the neglected tropical diseases. The WHO defines neglected tropical diseases as a group of diseases that predominantly affect populations in the tropics that are amenable to control by a combination of various interventions. And we previously had 17 such conditions. Recently we had new additions. In 2016 we had chromoblastomycosis and other deep mycoses added. Fortunately not a problem in our part of the world. And then last year we had scabies and other ectoparasitic infections added. And finally last year they also recognized snakebite envenoming as a neglected tropical disease, which something more can be done about. So if you look at the 20 neglected tropical diseases or NTDs, we have 15 of the 20 in our region. Now we often talk about Asia growing very rapidly economically, and you would think that these diseases have disappeared or they're fast disappearing. But unfortunately, they are still very much present here. And so, for Siamo-TropMed and for IMU, when you're training your future clinicians, it still is pertinent for us to remember that we are not, and we should not be thinking only about the huge NCD burden, but we also have to think about the vast diversity of the neglected tropical diseases and the challenges they pose in detecting them, accessing treatments, and actually treating them. I'm not going to talk about all of them in detail. I'll spend some time on the elephant in the room of NTDs. But wait, before I go there, I'm going to talk about the progress on malaria, HIV, and TB a little bit. So for malaria, we are making progress. And as you can see, and maybe you are aware, we are aiming to achieve elimination in 3 countries by 2020. And 3 of those are on track. China, our biggest country, does not report any locally transmitted malaria since the last few months of 2016. So for the first time, we had 2017 with no locally transmitted malaria in China last year. And so they are on track for certification by 2020 if that situation prevails. The other 2 countries are Malaysia and the Republic of Korea. And Malaysia is also making good progress. If you look at indigenous malaria, human malarias, not Nowlacey, because I mean, Nowlacey you have about 2,300 cases being reported, and as I said, that's a zoonotic malaria for us. If you're looking at the human malarias, the numbers are down to about 400, and of that only about 100 are among indigenous people. The others are all among migrants. So it's a good job. We have still 3 years to go, and we are optimistic that Malaysia can get there. The third country is the Republic of Korea, who is also on track. They have less than 300 cases now. A lot of the cases were concentrated along the border with North Korea, and with the improving of relations between North and South Korea, we are optimistic that we can add momentum to that push and possibly get there by 2020. Other countries, we still have challenges. Of course, the Western Pacific region also includes 3 countries from the Greater Mekong sub-region, Cambodia, Laos, and Vietnam, which also deal with the problem of artemisinin resistance and multi-drug resistance. And so we have a particular challenge that is of a global health concern, because this is the only place in the world that we have artemisinin and multi-drug resistance reported. And it's really important that we contain it there and eliminate it there. So we are looking at a strategy of accelerated elimination from the Mekong to get rid of the falciparum resistant strains and prevent their spread further west to India or Africa, because that could have very severe implications on the global malaria effect. Of course, we are not doing well on a global scale. The World Malaria Report showed for the first time that progress has stalled. We are reversing the successes gained in the last 15 years. And a lot of that is related to funding challenges. But it's also a huge challenge because nearly 70% of the global burden now comes out of 11 countries. The 10+1, which we talk of 10 African countries and India. And so we need to really do something to push that agenda forward. And there is a new WHO initiative that will be announced in a couple of months, exclusively looking at that. That's beyond our region. So for HIV, we're doing good. 73% diagnosed, but only 55% on treatment. So this is an ethical dilemma, because either people drop out or they don't have access to treatments. And this is dangerous. Access to treatments is becoming better because treatments are becoming cheaper. But governments are also looking at sustainable financing. As you know, a lot of the progress on HIV was largely funded by the Global Fund for AIDS, TB, and Malaria. But that money for HIV is now significantly declining. And so national ownership of treatment efforts will need to be strengthened. I believe that international funding for HIV is going to reduce further after 2020 and the current Global Fund funding round. And so governments need to take on this responsibility. For hepatitis, we are now helping countries develop national action plans. 11 countries have done burden estimates, and we are working with health ministries to expand access to the availability of drugs. The STIs also remain a big challenge in our part of the world. You read probably recently publications of the first cases of multi-drug resistant gonorrhea being reported, emerging from our part of the world, which poses the challenge that this is still a challenge in this part of the world that needs to be addressed. We talk less about the STIs and talk more about HIV now, but actually the STIs still remain a big challenge. In the Western Pacific region, we are also talking about elimination of mother-to-child transmission of syphilis. We have a regional action plan aiming to achieve that. it's an important area where we have effective drugs and it can be done. And so we are looking at cross-cutting interventions that will impact on multiple diseases, but also impact on multiple challenges like antimicrobial resistance. So as a global community, we are recognizing the need to address antimicrobial resistance, have strategies in place for rational use of antibiotics to prolong their use, not only in health, but also in agriculture, animal husbandry, because it's being increasingly recognized as that there's massive consumption of antibiotics in those areas which are impacting on the resistant status of microbes in human populations. So we're coming back to that One Health approach, and I'll talk about it a little more in detail further on. And so we'll now talk of the NTDs, and I said that the NTDs are amenable to control, elimination, or eradication. Why 5 groups of interventions. A lot of the progress we are achieving in the region is attributable to preventive chemotherapies, so mass drug administration with cheap, effective drugs donated by pharmaceutical companies to WHO has made it possible for us to eliminate and control a lot of the neglected tropical diseases. For your information, across the world, last year for the first time, we exceeded more than 1 billion doses of mass drug administration. That's the scale of the NTD challenge that is being implemented across WHO regions, largely in Africa, but also still significantly in the Asia Pacific. Increasingly, and I'll talk to it a little later when I talk about progress, we're also recognizing that we're going to need cross-cutting interventions, intersectoral collaboration to push the NTD agenda. And the other areas like safe drinking water, sanitation and hygiene becomes imperative. How do we ensure that everybody has access to that? Effective vector control is a huge challenge. People ask, why is the dengue the elephant in the room in neglected tropical diseases? Because we don't have effective vector control tools for the dengue vectors, because we don't have effective vaccines, because we don't have effective treatments. So we are looking and we are pushing a lot in the vector control space. You may be aware that the World Health Assembly last year endorsed the Global Vector Control Response 2017-2030, which looks largely at scaling up vector control capacities in countries and shifting to sustainable vector control. It is imperative that we recognize this as an important area in public health. And if I may quote our previous Director General, Dr. Margaret Chan, when she asked that the Global Vector Control Response Strategy be developed, she acknowledged that we as a public health community had dropped the ball on vector control. And this was in the aftermath of the Zika outbreak that affected largely the Pacific and South America, but also concurrent outbreaks of yellow fever in Africa. And so there was clearly a need to revitalize vector control. And move away from traditional vector control and look at new tools and new approaches. And Professor Pratap is moving his head because he knows if I start talking about that, I'll need a 1 hour. So I'm stopping there on that. But veterinary public health is also important. It's a critically important area that we've recognized. And WHO is providing leadership by having a tripartite agreement now with the Organization for Animal Health, the OIE, and the FAO to push the One Health agenda in this part of the world. It's important for many entities, and I'll talk about them later, and then case management, because even if we reach public health elimination of neglected tropical diseases, the residual morbidity that those diseases have caused will remain, and so people need to have access to managing those residual morbidities. But all of this, we have realized, cannot get us there if we don't educate and empower communities. It cannot be driven by a health ministry or by intersectoral action if the communities are not empowered, if the communities don't recognize the need. So this is what we are now looking at. So a few words about the elephant in the room, dengue. Do I need to talk about dengue in Malaysia? I don't need to. We know globally we have nearly a 50-fold increase, or 30-fold increase of cases over the last 50 years. Is it purely an increase in dengue? I would say no. It's also that we are getting increasingly better at detecting it, at reporting it. But that doesn't mean that we are doing a good job with it. And as your previous health minister, Dr. Subramaniam, said, the key challenge of dengue is that we in the regions are not doing enough to push the dengue agenda from a research perspective. Because dengue is one of those diseases that is largely ignored internationally. And as Professor Pratap earlier said, until we recognize that it's a regional challenge, it's a tropical challenge, and we need to do something, we need to start investing and finding solutions, it's going to remain a challenge. How big is it a challenge? As I said, the burdens are increasing. But we are doing well in the sense that we are reducing the case fatalities. So in 2016, when we went to the Regional Committee of Ministers with a new regional action plan for dengue for the Western Pacific region, recognizing the lack of tools, what we said is that we can do a better job of reducing the deaths. We reduced the case fatality from 0.3 to 0.16. But in countries like Singapore, it's less than 0.1. So we are saying over the next 5 years, we can still halve the number of deaths. Why is dengue a big challenge in our communities? Because it causes deaths. If we can remove the deaths, we turn dengue into influenza, right? A periodic infection which comes, causes disease and goes, and will not be a big issue. But it's the impact, the deaths, that is the challenge. So what we can do with what we have at the moment is doing a better job in managing the cases. If we can reduce the case fatalities with the available tools, we're going to be changing the dynamic. But then at the same time, we also need to see how we can actually reduce the burden of cases. And that's where the new initiatives, the novel tools come in. And so we are pushing new vector control tools, Wolbachia, Oxitec. We are also looking at new vaccines. As Pratap mentioned, Sanofi, we were optimistic, but now we see that we have challenges. It tends to cause severe dengue in previously non-exposed individuals. But if you really look at the data, it seems to have a very good protective effect on previously infected people. So how do we define who is infected, who is not infected to get the vaccine? That's a challenge. But then we have good candidate vaccines where we will not have that challenge. So we have, it appears, still unconfirmed. We are working on finalizing the data and the evaluations. The Takeda vaccine, the NIH vaccine, could potentially be good game changers for the future, in which case we may be able to show progress. But what does dengue do to us? The aggregate cost of disease illness. So you see that 3 countries, Indonesia, India and Brazil, are responsible for 50% of the aggregate costs for dengue globally, right? Now one of those is an ASEAN country. But I'll ask you to look beyond the red line, and then we have 3 countries which are very much home to us, the next 3 countries, bearing the highest aggregate costs of dengue globally. So it is draining our economies. We need to do something. We need to find a solution quickly. And if you look at it from a regional perspective, you find that we are more than half of the global costs as a region is here in this part of the world. So it's a huge challenge. And where does that costing break down into? 1/3 of it is ambulatory non-fatal cases expenditure. A lot of that is out-of-pocket expenditure for patients. Non-medical, non-fatal cases, hospital, non-fatal, and fatal cases. So the expense is not only in managing severe cases. We have a false view that the dengue expenditure is largely to manage severe cases. It's not. It's across every clinical entity that across dengue. And now I show it to you in a map. And again, if you see the per capita cost for dengue, I put this map because we are in a red area, the only red areas in the world. So that's why I said this is the elephant in the room. We cannot ignore it. We need to find something quickly and do things differently. Lymphatic filariasis. I have not had the good fortune of knowing Professor Mack closely, but I've had the good fortune of knowing Professor CP closely. We've been working probably for the last 10 years, Professor CP as one of our advisors in the regional program review group that helps us advises WHO in the region on progress in lymphatic filariasis, and singularly the Western Pacific region is the most successful region globally for lymphatic filariasis. And a large part of that is because of the leadership and expertise of people like Professor CP, Professor Ma, and many others in this part of the world who have made that possible. You may recognize somebody in that photograph. This is the 2016 Regional Committee meeting of ministers in Manila. And we were celebrating the elimination of lymphatic filariasis in 3 countries. You see the health ministers of Cambodia, Vanuatu, and Cook Islands. And you have Margaret Chang and our regional director, Dr. Shin Yang Su, But you also have the chair of the regional committee, Dr. Subramaniam, who was your Minister of Health at that time, who chaired the regional committee that year. So we were celebrating for the first time the elimination of lymphatic filariasis in 3 countries of the region. The first 3 countries since China and Korea were certified as having eliminated in 2007. And then last year we added 3 more countries. So we added Marshall Islands, Niue and Tonga. So we have now 6 countries validated as having eliminated lymphatic filariasis in our part of the world. What for the future? We have 7 more in the pipeline. This year in October we will be probably celebrating Vietnam's achievements. And other countries maybe later next year. Of relevance to you, we did another expert consultation here in Malaysia last year, and Dr. Lokman chaired that meeting, if I remember correct, because we, for the first time, realized that Malaysia has made incredible progress, but you're having a few resistant foci due to, many of you know there's 2 forms of filariasis that caused by Wuchereria bancrofti and Brugia malayi. And in Sabah, the foci where Brugia malayi is active, we were not progressing. So we have residual transmission still persisting there. 2 implementation units, Tangkarasan and another one, which we are working very, very intensively with the Ministry of Health Malaysia. We've done MDAs recently and completed. And we are hoping that Malaysia will meet the 2020 deadlines. So, and we will be able to break that cycle there. Basically, I mean, frankly speaking, we are optimistic that 21 of our 22 affected countries will reach the 2020 deadline. The only challenge may be PNG. Some countries have a challenge because elimination of lymphatic filariasis requires 5 rounds of mass drug administration with a combination of diethyl carbamazine citrate and albendazole. WHO recently endorsed a triple therapy, which adds ivermectin to the 2 drugs. And this actually shortens the rounds of MDA to 2 years. So we are already implementing or planning implementation of the introduction of triple therapy in PNG, in Tuvalu, in Fiji, where we are having particular challenges to actually accelerate achievement of elimination. I now move to blinding trachoma. It's still a challenge in some of our countries. Again, we were among the first countries after Morocco was validated to validate elimination of blinding trachoma. Last year we validated 2 countries, Cambodia and Laos PDR. We are making progress in China. China's dossier is already up for review. We are optimistic that we can have China validated by the regional committee meeting this year. We have MDA going well in Kiribati, Solomons and Vanuatu. blinding trachoma still remains a problem among the indigenous communities of Australia, the Aborigines. And so we're working very closely with Australia, and we have one district in Vietnam where we haven't still reached progress, which would mean that we have Fiji and PNG who may not meet the 2020 deadline. Schistosomiasis, I like to call it Asian schistosomiasis, is a particularly big challenge to communities that are affected by schistosomiasis. We're not talking Schistosoma mansoni, which you get in Africa, but we're talking Schistosoma japonicum and Schistosoma mikangai, which affects 4 countries across our region. The only country that has achieved elimination is Japan. China is making very significant progress and is also helping us with progressing the agenda in the Mekong countries affected Laos and Cambodia. But we also have a huge challenge in Schistosoma japonicum in the Philippines. And the particular challenge of japonicum is that it has an animal reservoir, water buffaloes. And so it's more difficult to control than mikangai, which to our knowledge doesn't have an animal reservoir. So in May last year, we did an expert consultation based on the success that we have. And now we've identified criteria for validation of elimination of schistosomiasis for the first time. And we are hoping that we can have a regional goal of eliminating schistosomiasis by 2025 and complete the verification process by 2030 in many countries. What we saw is that we can't progress the agenda by just doing MDAs. We need to address the challenge of water and sanitation, prevention of reintroduction. And that's what we've discussed in the expert consultation, how we work jointly with water and sanitation, animal health to prevent the infection of the water buffaloes and also the pollution of the waterways, the Mekong River, to progress the agenda. So we've introduced what we call a community-led water sanitation program. In Laos and Cambodia, we are seeing a good uptake in the sanitation, water sanitation, working with communities, empowering them to actually prevent reinfection and comply with enhanced treatment compliance, which we believe will help us move the agenda of schistosoma. Leprosy still remains a huge challenge for 3 of our countries, particularly the Federated States of Micronesia, Marshall Islands, and Kiribati. If you look at the major leprosy indicators in the region, we're doing well in comparison to the world. We have nearly 4,000 cases detected last year in 2016. Our new case detection rate is very low, but that's also an indication that maybe we are not detecting what is out there. So we shouldn't get too complacent. We still have a prevalence of nearly 6,000 cases in the region. But otherwise our indicators are good there. The burden, as you can see, is reducing rapidly. And so we are hopeful that we can move this agenda. If we identify the top 10 countries for leprosy, we still have a challenge even here. You have about 200 cases. yaws. Trypanemma pallidum affects 4 of our countries. The Philippines, we just found out last year that there's yaws in the Philippines. Otherwise, we thought it was Papua New Guinea, Solomons, and Vanuatu. We're doing well with the elimination efforts. As you know, azithromycin, a single dose, seems to be the treatment of choice, so it removes the need for benzathine penicillin injections. And so we are seeing very good results, if you can see, in the Solomons and in Vanuatu. So we are optimistic that we can progress the agenda. PNG remains a challenge because of access. Soil transmitted helminthiasis is still a problem among many of our people. We have school-aged children's deworming. As you can see, we have still a long way to go in some countries. And we are reaching only a few people, and actually, if your school attendance is weak, that means we are not actually covering the full school-age children population, because we are using schools as the entry point for this intervention. So this is still an area of concern for us, but we don't have donors to expand access to the treatments. The countries that are doing well, Cambodia, Laos, Vietnam, but there are still isolated pockets there where we have very high prevalence rates, even in these countries. The foodborne rheumatoidiasis. So we are talking Clonakis, Opisthorchis, and we also talk at the same time about teniasis and cysticercosis and echinococcosis. So all of these in one cluster, because they are all requiring one health approaches. What's not good is that if you look at the global burden, we are only second to the African region. And who contributes to that? Paragonomasis, Opisthorchis, Clonakis, cysticercosis, and echinococcosis, the big challenges. We've seen some interesting publications in the Philippines about confusing TB with paragonomasis infections, and the need to differentiate them. We did an expert consultation looking at accelerating this agenda, and we are now trying to move the agenda for the FBTs and for cysticercosis and echinococcosis. The meeting which we did in May 2017 in Korea looks at increased collaboration with the OIE and FAO. And we are now looking at mobilizing funds, but to mobilize funds we need to have specific business cases, action plans. Huge burden of FBTs in China, in Korea, and you know that Clonakis, multiple treatments are also linked to liver carcinomas, and that poses a particular challenge. So it's not just effective enough to have treatments, praziquantel, but also to prevent reinfection, because otherwise there is a linkage with the possible emergence of liver carcinomas. Cysticercosis, teniasis is a huge challenge. Neurocysticercosis is a challenge. I can see Dr. Priyadarshini Sahu here, who joined us at a consultation in Manila last year. to address the problem in the Philippines, but it's also a challenge in other countries in the Mekong. WHO has come up with a lot of new guidelines on how to accelerate the agenda. And it's again a One Health approach. You need multiple interventions. You need to strengthen food safety. You need to change practices. Across our region, eating raw fish is still very acceptable cultural practice. And if it's from the sea, it's okay, but when you're eating river fish that are carrying parasites, you end up with these problems. So how do we inform communities to change their practices and protect themselves? Rabies, an item which hasn't progressed. We still have about 60,000 deaths due to rabies globally. The need for us to do something quickly. So that's the global burden, and you see uncomfortably dark areas in these parts of the world. It's 100% fatality. Dog bites are thought to be attributed to 95% of the cases. The biggest challenge with rabies is access to the vaccines and the serum. And that's what we are looking at, how do we make it happen? And also the dog vaccination programs, the problem of strays. So in May this year, a tripartite program introduced 0 by 2030. This meeting was in Kathmandu, Nepal, looking at progressing the rabies agenda. I'm going to accelerate a little. So the future, where are we going? What do we have? We still have these big challenges, but then that's not the end. There's emerging new challenges. Tick-borne encephalitis across Mongolia, China, Korea, Japan is being increasingly recognized as a challenge. Nipah virus fever, Professor Pratap mentioned, so I don't need to mention it. Small mutations could mean a devastating change to communities impacted by it. Melioidosis, big problem in our part of the world. Anisakiasis is a new emerging problem which we were not aware of. So there's newer challenges emerging. We thought we had the chapter on tropical diseases was over, but we are seeing new entities emerging or old entities emerging with new challenges. Like we thought the job of guinea worm was completed in Africa. And we were down to double-digit numbers globally. We are looking at eradication. And then we find that the guinea worm has transitioned into dogs. And so the whole program is now challenged. How can you actually achieve eradication of guinea worm if there is a natural reservoir out there in dogs? So we have a challenge. So the agenda is by far incomplete. There is a long, long way to go for us. What for the immediate future? The Sustainable Development Goals of the UN recognizes an end to the epidemics of AIDS, TB, malaria, and the neglected tropical diseases, and to combat hepatitis, waterborne diseases, and other communicable diseases. So if you remember the MDGs, the Millennium Development Goals, didn't have all of those ones. Now we have an agenda which we need to address. This is signed off by the UN General Assembly, and this is what we are trying to do. And to achieve this, WHO is pushing for universal health coverage, access to commodities and treatments, diagnostics, care, through under the umbrella of UHC. This is going to be our mantra for the next 10 years. And if we do that, we may achieve the end to the epidemics. But the new challenges may then take the place. Thank you so much. My thanks to also the people who contributed to my presentation.
Thank you, Dr. Rabindra, for the very informative talk. I think we are running a bit out of time. I think you have questions. Please direct to Dr. Rabi during the panel discussion. Okay, so with that, we end today's session. I think we have a very fruitful session today. Thank you to all the speakers.
Thank you, Dr. Rabindra and Prof. Pratap. We will now take a break for tea and poster viewing until 11:30 a.m. outside the auditorium. Poster judges are requested to please meet at the registration counter for a briefing, and poster presentation participants are reminded to be at their stations to await the arrival of the judges. A note to MMC Malaysian Medical Council members: to claim your CPD points, please drop by the registration counter to provide your membership details. We would like to remind attendees to be back in the auditorium by 11:30 a.m. for the next session. Thank you. Good morning. We will now begin the next plenary session, which will be chaired by Associate Professor Dr. Siti Noshina, MSPTM President.
Thank you, and a very good morning, everyone. Okay, the person who I'm going to introduce needs no further introduction. He is Professor Datuk Dr. Lokman Hakim S. Professor Datuk Lokman has served directly under Prof. Mak Junwa as a medical research officer in the Malaria and Filariasis Research Division between 1991 to 1995, followed by as the head of Parasitology Division when Prof. Mak was made the director of IMR. Until he retired in 1997. He also took over from Prof. Mak the deanship of the Simeo Trop Med School of Postgraduate Diploma in Applied Parasitology and Entomology. In 2009, he was then transferred to the Ministry of Health as the Director of Disease Control before assuming the post of Deputy Director General of Health, Ministry of Health in 2017. And finally joining IMU. He was the past president of the College of Public Health Medicine in the Academy of Medicine Malaysia, and currently serving his 3-year term as member of the advisory group to WHO Director General on pandemic influenza pandemic preparedness framework. Without further ado, Professor Datuk, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all of you. Thank you very much, Professor Sharina, for the kind words of introduction. It will not be possible for me to cover every aspect of tropical medicine in the next 45 minutes, so I have deliberately confined my presentation to issues and conditions that poses some policy and issues and challenges. In reminiscing the tropical medicine research in Malaysia, I will not be doing justice if I did not mention the history of Institute for Medical Research. The history began with Sir Patrick Manson, the father of tropical medicine. Then he was then the medical advisor to the British Secretary of State of the colonies, where he pledged aids to the colony office for scientific research into the causes of tropical diseases. And he announced the intention of establishing schools of tropical medicine in the United Kingdom way back in 1898. And within months, the Liverpool and the London School of Tropical Medicine were opened in 1989. And following year, just a year after that, in 1900, the first research outpost of the London School of Tropical Medicine was established in Kuala Lumpur. And it was named the Kuala Lumpur Pathological Institute then, which became the foundation and remained as it stands now, the Institute for Medical Research. In the words of the British Resident General, Sir Frank Swettenham, in his congratulatory message, IMR will be devoted towards a scientific and sustained research into the causes and the means of preventing and curing such causes as beriberi and all forms of fever. I like what CP was saying. If you focus on science, you will grow up. But when you start involving politics, you will suffer. And that's what exactly happened to IMR. The establishment of IMR was the landmark occasion that propelled IMR to glory in the tropical disease research. Many early studies from IMR contributed to our understanding of biology, ecology, the transmission dynamic, diagnosis and treatment of very many tropical diseases such as malaria, lymphatic filariasis, beriberi and scrub typhus. Dr. Hamilton Wright was the first director of IMR, who wasted no time in studying the twin causes of beriberi and malaria. And within 1 year as the director, he already published the first two institute study series, the malaria, fevers of British Malaya, and an inquiry into the etiology and pathology of beriberi. These were published in 1901 and 1902. Just imagine how productive they were. 1 year after establishing the institute, they already start producing scientific documents like that. In fact, this institute was also the training ground of the early local legends in various disciplines of tropical medicine. People like Dr. Lim Boliat and Dr. Natacham. They are there in the pictures. Those pictures were taken in 1947. And also people of the recent past, outstanding researchers, such as our Professor Emeritus CP and Professor Emeritus Mark Chongwa. Now, with regard to MSPTM, two names were legendary. Professor A. Sondashuk, the author of the book Malariology, which remains relevant reference text till today, was the first president of MSPTM when it was officially established in 1964. And the address of MSPTM has remained till today, the Institute of Medical Research. Datuk Dr. Unku Omar was the first Malay to become director of IMR, an eminent pathologist, but public health at heart, highlighting close link between poverty and health, such as worm infestation and malnutrition. He was indeed very instrumental in getting IMR into international collaboration. And in fact, he was among the leaders that actually brought IMR into the CMAT program, and later on, CMATROPMED. Now, in a more recent past, we have also great names, to me, the great giants of research in tropical medicine. They say that when two giants are together, the grass will suffer. I think I believe in that. And it's somewhat fortunate that history has made it that both of them move in a separate way. CP went to USM to develop the School of Biological Sciences in USM, and Marx continued in IMR to develop IMR, and CP went on to WHO. I call them the great scientists and scientist diplomat, especially Datuk Professor C.P. Ramachandran. CP started his career in IMR. He is truly an accomplished scientist and scientist diplomat, because as chief of scientists of WHO Flaresis program, he was instrumental in getting research carried out globally on ivermectin for a safer alternative to treat and control onchocerciasis, the major cause of blindness in Africa. The discoverers of ivermectin, Professor Toshi Imura and Professor Willem Campbell, were awarded the Nobel Prize in 2015. He is a scientist diplomat par excellence because he could put together a global strategy of elimination of lymphatic filariasis through a World Health Assembly Resolution 1997. This is what we know. If you understand the mechanism of the World Health Assembly, you can understand lots of process of negotiation and that before every member state agrees on anything. And this man is able to put all this head together and come up with this global elimination program. And it doesn't stop there. He managed to bring the global community, pharmaceutical industries, philanthropists, to help to support the implementation of this strategy. Bill Gates Foundation, for example, pumps a lot of money to make sure that all these drugs are given to member states, mainly of the very poor countries, with support in terms of free drugs for the mass drug administration. And the impact of this program is remarkable, very remarkable. After 15 years, in 52 countries, the infection rate has been brought down from 120 million to only 50 million recently. And the prospect of interrupting the total transmission of this particular debilitating disease is very real. Lymphatic filariasis has been eliminated even in Peninsular Malaysia. As mentioned by Dr. Rabindra just now, we still have a small foci in Sabah and Sarawak, and we hope by 2020 we'll be able to declare that. And for his work, Professor CP was awarded the Mary Kingsley Medal by the London School of Tropical Medicine in 1999, placing him among the list of international distinguished leaders of tropical medicine and public health. On Prof. Mark, our Deputy Vice Chancellor has described him in full. In fact, what I'm going to suppose to say is, has been said by Prof. Peter Pope. Probably what I can say is, if you consider that I've been a successful person in tropical medicine, the person that's been responsible for that is Professor Mark Chungwa. In fact, he was my teacher, he was my mentor, he was my boss, and he has significantly influenced how I progress in my academic as well as administrator role. Now, when there's much talk and whispering that IMR has, in recent years, lost its lusters and moving down the memory lane of tropical research, it is actually comforting news to hear that IMR, young scientists and teams, has won a prestigious WHO award, the Dr. Lee John Wook Memorial Prize for Public Health, in their work on maggot therapy. I would like to congratulate Dr. Nazni Ahmad and her research team for this achievement. Now, although Malaysia is experiencing a clear shift in health burden from acute infectious diseases to chronic non-communicable diseases, the challenges of the unfinished agenda and the unexpected in tropical diseases is quite considerable and cannot be ignored. We are very vulnerable to damaging zoonotic infection, which can cause severe pandemic and tremendous socio-economic loss. Since 1940, 60% of emerging infectious diseases were zoonotic in nature. Predicting zoonotic infection is difficult and almost impossible. While the source of the infection is the animal, the human is at the receiving end. Lack of ownership and shifting responsibility between various stakeholders is a major issue, undermining effective and efficient management of the risk and control of emerging zoonotic infection. And we, Malaysia and the Southeast Asian region, countries are in the hotspot of emerging zoonotic infection. The known drivers include human population density, change in human population density, and wildlife diversity. While we are at risk of being infected with newly emerging pathogens, at the same time, we are still grappling with the existing endemic zoonotic infection of public health importance in Malaysia. In order to get a better picture of the situation, the Ministry of Health decided to enlist leptospirosis in the schedule of notifiable diseases in 2010. And since then, the incidence of leptospirosis continues to increase, peaking in 2015 with an incidence rate of 27.2 per 100,000 population. Now, comparison between countries is difficult because differences in the notification practices as well as the diagnostic method being used. Nevertheless, the reported incidence of 27.2 is much higher than that reported incidences in Sri Lanka at 11 per 100,000, Cambodia at 7.7, but lower than Thailand at 40, and Seychelles at 101 per 100,000. The incidence is also highly fluctuating on a weekly basis, but generally it peaks at the end and the beginning of the year, coinciding with this monsoon and the flooding season. In contrast to the popular belief that the problem is mainly in natural recreational areas, such as the waterfall park, reported outbreak in Malaysia mostly occurred in urban residential areas as well as in the rural community settlements. That is within the vicinity of human habitation itself. This drives an important point that leptospirosis in Malaysia and as everywhere else has gone beyond the occupational hazard to become a living hazard. It boils around the issue of environmental cleanliness and hygiene, issue of food wastage and waste management. And while individual habit of food wastage is deplorable, the management of the waste and urban sanitation is also much to be desired. I always say that there's no city in the world that are free of rats. In New York, in Tokyo, in Singapore, there are rats, but they are confined to the sewage system. That's where they find the food. How do I know that? I watch Batman movie. Have you watched Batman movie? The rats are all in the sewage system. But in this country, you just go to any popular eating outlets, you will see the rats bigger than the cats. Why? Because there are ample food source up there on the surface. So why must the rat goes down to the sewage system to get their food? Now, management of environmental sanitation in this country is under the local government. And unless they take the ownership of leptospirosis as part of the overall environmental sanitation and waste management issue, we will continue to live with this problem. Not only leptospirosis kills, rats has created an embarrassing reality for those who cares. For example, not too long ago, it made headline in one of our modern teaching hospital being infested with rats in the ward. Patient can see the ward running around in the lab. And this hospital is supposed to be the cleanest place in the world because otherwise they cannot be certified to carry their business. Indeed, the root problem of this is because of the food stall across the road. They share, the main monsoon drain shares with the same drainage of the hospital. So the rat goes and eat at the stall and will go back to the air-conditioned room to stay and breathe. And that's what's happening. But what more ironic is the thinking of how to address the problem. It was reported even in one of the newspapers that some of this top management is saying, okay, we will breed the owl so that the owl will eat the rats. But I can tell them, in no short time, the owl will also die because of obesity. Too much of rats to eat. After only they took the action on the stall, that the problem actually been resolved. No, Malaysia has a fair share contributing to the list of newly emerging infection in the form of Nipah virus in 1999. I'm sure some of us here had the opportunity of experiencing firsthand the excitement, turbulence, drama, chaos, and initial sense of helplessness and final relief in managing this severe, devastating outbreak. Looking back, the emergence of Nipah virus is a classic example of how anthropogenic factors drive the emergence and how unprepared we were in managing such severe threat. It cost us a direct loss of more than 2 billion Malaysian ringgit from a collapsing pigs industries. But do we learn from these terrible incidents? Based on my 8 years at the Ministry of Health, I must say that we have forgotten the lesson. I personally feel that so because the level of intersectoral cooperation and information sharing is much more to be desired. Our national resources with regard to laboratory support is still fragmented. And the Center of Disease Control, which I helped to propose way back the year 2000, after the Prime Minister then, Mahathir Mohamad, made a bold statement at ASEAN Summit that the region must have a CDC-like laboratory. And I was sent to CDC Atlanta together with Datuk Ramli at that time. And we came back and put up the proposal. As what CP says, when politics get into the picture, the CDC become CDC that, become CDC this. And until today, and now the same person has become the Prime Minister again. I'm just worried that he will ask, where is the CDC Malaysia? Until today, that CDC has yet to be put to be established. Interestingly, it will be much more challenging now to do what we thought is the right thing to do with regards to managing the affected animal. In a recently published article, it is becoming more difficult now to justify the culling of animals. Remember, during the Nipah, to stop the transmission, we basically have to kill all the animals. Thousands of animals, and we employed the army in the shoulder to do, soldiers to do the shooting at that time. Try to do that now. And this is what reported in Singapore, that the people doesn't seem to agree with this. And we might brush it off because, well, Singapore doesn't have an animal farm industries. But it's already happening in this country. Remember, witness, when we have the problems of suspected rabies outbreak in the northern state of Kedah, Perlis, and Penang, when we are trying to manage the stray dogs, all those NGOs for animal love are standing up there. No, don't touch the dogs. So this is the kind of challenge that we are facing now in deciding in between public health and animal love. I don't know. We had a crude shock with regard to rabies. A fatal infection if not treated correctly and early. The official statistic of the Disease Control Division showed that there's no rabies all these years as of to 2016. In fact, the Department of Veterinary Service has made an official declaration in 2012 that Malaysia is free from rabies. 2012. Barely 3 years after that rabies-free declaration. we were caught by surprise in 2015 of an outbreak of suspected rabies, human rabies, in the northern state of Police, Kedah, Penang. But it was not laboratory confirmed. We couldn't confirm it. Honestly, I was the deputy DG at that time. I was frantically trying to get the information on the rabies prevalent in the animals. I'm not getting it because I need the epidemiological link to prove that this is actually human rabies. But I couldn't get until I retired. And that is the state of One Health we are talking about. Professor Pratap, the Maihun, not Mihun. So I thought it was correct, Mihun, that's why it doesn't work. Because we Mihun, we just eat it, it's gone. As mentioned earlier, it is almost impossible to predict new emerging zoonotic pathogen. But in the case of this endemic disease like rabies, there are already telltale signs that we need to pay attention. Rabies is still endemic in Thailand, which is we border them, is our bordering us in the northern state of Peninsular Malaysia, and Indonesia to the south of the North Borneo state of Sabah and Sarawak. Cross-border dog control, movement, and rabies virus surveillance are critical to prevent the introduction of rabies to the country. But how much does our border patrol appreciate the importance of such border control? And how extensive and comprehensive is the virus surveillance is something that we need to know. And 2 years later, in 2017, the stark reality faced Malaysia public, the first confirmed rabies death after 20 years. This time it struck Sarawak. And what the coincidence, the press statement made of this by the Ministry of Health was issued on 1st July 2017, which was my official date of retirement. I was very relieved because I don't have to answer to the press. And the war against rabies still continues to this day. And we continue to record unnecessary fatality because of this. In the slide, there was 7 deaths. We already have 8 deaths. The last was on 3rd May. 9 deaths, 10 deaths already. As I'm speaking, people are dying there in Sarawak. It is interesting to note that vaccinating all dogs is the main strategy. But I'm wondering how the state government is implementing this program, especially in dealing with the stray dogs, which is the highest risk for us. Now, while public assurance and risk communication are critical in managing the outbreak, it remains a question as to why. Why must the MOH take the lead and ownership on this problem? Licensing dogs and requirement for vaccination is under the purview of the local government. Managing stray dog, which is a public nuisance, is also under the purview of local government. So unless the local government take the ownership of the problem, we cannot ensure the efficiency and effectiveness of the control program. And our Deputy Health Minister has no control over the local government. So why the hell is making the announcement and telling that everything is under control, what's not? So now we move on to another area. There's a strong sense of optimism among the global community, as mentioned by Dr. Rabindra, that we can now talk about eliminating local transmission of the malaria. And WHO announced the global agenda during the World Malaria Day in 2016. And the optimism stemmed from the fact that we already have all the effective tools to tackle the 4 components of malaria transmission dynamics. Namely, we are able to protect the host, we can treat the infections, we can manage the vector, and we can manipulate the environment that promote the breeding. Well, indeed, we are progressing well in the local context. Human malaria incidents continue to decline steadily, and in many states are now malaria-free in this country. We can even manage to eliminate PYVACs, despite the challenges of having to treat them for over 14 days to remove the parasite. But our concern is the increasing trend of P. knowlesi. It is now the most dominant species infecting human in Malaysia. And the proportion is high in Sabah and Sarawak, contributing to almost 2/3 of all the reported cases. Now, as such, an important question was raised. Will simian malaria or monkey malaria impact on the global program to eliminate malaria? I shared my thought on this at the 5th Asia Pacific Conference last year. The infection can impact on global elimination if human-to-human transmission occurs. And so far, we are very lucky as there is no evidence as yet to show human-to-human transmission. Indeed, the infection foci, if you look at this map, between human malaria in the blue dot and the knowlesi in the red dots are very distinct. They don't share the same location. All right? With the restricted distribution of natural hosts and the absence of compelling evidence of human-to-human transmission, the impact on global elimination program is considered not significant. So and WHO also seems to be holding the same principle now. Zoonotic malaria is different from the human malaria. So I hope the confusion is no more there. And furthermore, the distribution of P. knowlesi follows closely the distribution of the natural hosts, the 2 macaque monkeys, Nemestrina and fascicularis. And these macaques are restricted to only to Southeast Asian region. So there's no issue about this parasite affecting other regions of the world. Now, despite the wide distribution of natural hosts in the region, P. knowlesi in human is practically reported only from Malaysia so far. Only a few isolated cases here and there from Brunei and from South Thailand. And we have been importing some of these cases from Indonesia, for example. But Indonesia has not, so far officially notified the human infection of knowlesi. And this contention that simian malaria will not impact on the elimination program is further supported by the work of Imai et al. In 2014. From their very elaborate modeling studies, they indicate that there shouldn't be a problem to the program and local program manager because the existing strategy of using bed net and improving the access to care are good enough to manage the situation. But however, the problems of simian malaria brought about another bigger challenge in managing the ecosystem as a whole, in promoting the balance between socio-economic needs through commodity crop plantation, and therefore deforestation, and the impact on natural ecosystem, and the risk of having this monkey malaria. Now, our biggest challenge now is with dengue for this country. It is the most rapidly increasing incident disease burden in the world, and also in Malaysia, rising exponentially over the years. In Malaysia, dengue outbreak occurs in a cycle, with major outbreak occurring in about every 4 to 5 years. What is most obvious, the peak of each outbreak cycle is getting higher and higher. The last highest peak was in 2015, with more than 120 confirmed cases. Now, this cyclical pattern of dengue is occurring on a weekly basis. And within a year, it is quite common to see 2 or more peaks of dengue outbreak in this country. And Selangor and the Greater Klang in particular contributed 60% of the cases. So if we can manage dengue in Greater Klang Valley, we can manage dengue in this country. The red bar represents the notified clinical cases, clinical suspected cases, and the black bar are the lab confirmed cases. Now, considering the limitation in access to diagnosis, the estimated minimum number of dengue cases has been hovering over 2,000 cases a week, and we seem not be able to bring it any further. Over the last 3 years, if you look at this EPIC week, for the last 3 years, the minimum number of cases hang around 2,000 cases. We are not able to bring it down any further. To such an extent, MOH has been questioned for not doing the right thing. We have been blamed for not being able to control dengue. We are doing a wrong thing. Despite pumping 20 million ringgit a year on insecticide for vector control, the mosquito densities continue to increase. Now, with the current challenges of persistent problem, elements of uncertainty, and the unknown risk of emerging infection, the threat of cross-border health security, I reckon that tropical medicine is still an important discipline which warrant continued investment in trained human resource and research and development. Now, unlike malaria, dengue is still largely an unfinished agenda, not only for Malaysia, but also globally. With climate change, we can expect the geographical spread of this problem to some of the temperate countries. And in fact, local transmission, outbreaks of dengue has been occurring in some of these temperate countries, especially in summer. The real problem with dengue, unlike malaria, is the fact that we do not have enough effective tools. And this has been again stressed by Dr. Rabindra just now. We don't have enough tools to attack every 4 elements of the transmission dynamic. We have nothing for the virus to clear it off from the infected person to prevent it becoming the source of infection to the other mosquito. We have nothing effective to protect the host, the human host. We were hoping for the vaccine, but unfortunately the vaccine has come up with a lot of problems. Well, Prof. Pratap says that there's some promising new vaccine from the Takeda and also from the NIH vaccine. We hope that it doesn't have the same problem as that faced by Sanofi vaccine. So, and dealing with the super efficient vectors, we are actually at loss with regard to the control of dengue. As I said, vector control is not efficient because of the unique behavior of the Aedes in terms of its breeding and biting behavior. Now, these are some of the common breeding sites which is difficult to access because they're very private. Some in the bathroom, in the kitchen, they are breeding. And this is a common site in many residential areas in this country. We have a huge problem of waste disposal system in this country. Maybe in the large wealthy areas, that's not a problem. But those apartments, the low-cost housing, there's a huge problem of waste disposal. And how can we manage dengue if we have this kind of scenario in this country with us? We continue to explore new technologies and methods in trying to find sustainable solution to dengue problem. We participated in multi-trial center for new vaccine candidate. We experimented on the transgenic mosquitoes, but we have to abandon it halfway because of various challenges, issues and challenges. We are now experimenting the Wobacha with our international partners, and we are also considering SIT, trial insect technique, to address the problem. But to me, in whatever technology that you want to adopt, it has to be scientifically sound, feasible, practical, and affordable. And in this regard, I would like to share my personal experience. At the policy level, decision level, in dealing with the only commercially available dengue vaccine then, the Sanofi dense Vaxia vaccine. To me, this is the most significant public health policy decision that I've made that could have probably prevented some major disaster or even economic loss. The excitement about the long-awaited dengue vaccine was very high because we are just at the peak of our severe dengue in 2015. Then in 2016, Sanofi says that they are ready to register. And when they published the result of the phase 3 trial, Sanofi has indicated that they wanted to register this vaccine. So everybody was excited. I'm also very excited. But when you read the details of the report, of course, although there's a differential response in terms of efficacy to the various different serotypes, as low, some of it as low as 20 to 30%, especially for type 2. But the fact that the paper shows a very significant prevention of severe dengue, that make it very exciting. But there's also a caution that about 1 to 2% of the vaccinee, especially those who have no previous experience of tertiary infection, develop severe dengue. So that was where my concern is. So when Sanofi indicated their interest to register, we called for an expert group to discuss, and we were concerned. And I convinced the post-cap at that time meeting that we need additional information. So I was in fact suggesting for an extended trial, just to look into this 1 to 2%, to make sure that we are not facing a problem. Remember, even though the number of subjects was huge, 17,000, 1.2% may mean nothing. But when you're talking about millions to be vaccinated, that means a lot of things. And for public health people like me, that is my concern. That's why the difference between public physician and clinician. You all look only for 1 to 2 patients, but we look at the larger masses. So when making the decision, we have to be very careful about that. And I told the minister at that time, at least wait for WHO recommendation. There you are, WHO came up with the recommendation. But to me, this is the most convoluted, most difficult recommendation ever produced by WHO. They said that you can use the vaccine, but the vaccine is only recommended if you have high seroprevalence. If you have a robust dengue surveillance system, and you need to carefully consider issues like local priorities, predicted impact, cost effectiveness, country-specific hospitalization. I mean, what does it mean? To me, it says to me that WHO is trying to tell member states, don't use the vaccine, but in a very diplomatic way. And that's what I exactly told the minister. But the pressure was huge. Several professional bodies were challenging over the decision, and they made their own conclusion about the safety of the vaccine. Even eminent virologists in the country condemn us. And he was disappointed with our decision not to register. And they make it public. Influential professional bodies criticize us our decision for not heeding the WHO recommendation. But I just wonder whether they read the actual recommendation or they just read the Wall Street Journal that says WHO recommended the vaccine. The problem is the public take these views very seriously because they represent the professional bodies. And we were condemned for being illogical. So, but the pressure is much worse when Mexico, Philippines, and Singapore announced that they're going to register the vaccine. So I quickly checked with Mexico. Yes, they register, but they will think all a long time whether they want to implement it or not. Then I checked with Manila, with the Department of Health. Why are you registering this? I mean, for what reason are you registering this vaccine? To my shock, the response was, this is personal communication, and that's the importance of networking. Because we are friends in the ASEAN grouping, we can just call and ask. That was the honest response from them, that the decision was not made by the Department of Health of Philippines, but rather by the fund-rich Health Promotion Board. They bought the vaccine for millions to be given to the large number of them. And Singapore, interestingly, registered the vaccine, but they say it will not be covered under MediSafe. What does it mean? You register, but they say you cannot claim under MediSafe. So the government themselves still does not trust the vaccine. And that's what I told the minister. And we finally have to compromise. And the compromise was that we allow the registration, but there must be a compulsory phase 4 surveillance. Meaning, every single vaccinee must be followed up. And before my retirement, that was the decision. And when we told Sanofi about that, they did not put up their papers. And sure enough, Sanofi admitted the problem with this vaccine. And the rest is history. Now, the prospect of dengue control is not so bright to me, unless we have the effective vaccine that Rabindra Pratap was saying about. During a research to policy forum in Paris in 2016, where I participated, the result of the meta-analysis published early this year, the scientific evidence shows that very limited option that we have. We have very limited options. Right? In fact, the only thing that is really useful is community participation in removing the breeding places, but it's not an easy task to do. Right? Now, very quickly, the risk of another Nipah virus-like outbreak is real, because the natural host for this virus, fried fish, the fruit bats, is huge, expanding across continents. Recent studies have showed that repeated introduction of the virus prime the persistence and emergence of Nipah virus. And it is refute the earlier hypothesis that the El Nino phenomena drive the problem. And I think with what happened in Bangladesh and India actually support this contention. The virus is continuously being pumped into the community and creates the problem. And Bangladesh has been reporting Nipah virus almost every year. Almost every year. And the same fruit bat is also harboring Ebola virus. And there is serological evidence in Indonesia of the exposure of the population to Ebola virus. So, can Ebola outbreak occurs in this part of the world? You guess. Malaysia being centrally located and a popular destination for economic migrants, we are actually very challenged. the risk of re-importing those conditions that we have eliminated, like Bancroftian filariasis, is real. We have the vector in our backyard, Culex concupiscitus. And from our surveillance, the migrant workers from South Asia, India, Bangladesh, Nepal, they have very high microfilariemia rate. I'm talking about microfilariemia rate, meaning the microfilaria in their blood, ready to be taken up by the mosquitoes. And lymphatic filariasis is not included in the list of diseases in the Formema screening. So what's the risk? It's a real risk. Maybe 10 or 20 years from now, we will start seeing again the big legs and big scrotum. And the fact we have made a parasitical diagnosis of leishmaniasis in the case among orang asli. Orang asli. This poor chap has never gone to outside Malaysia, the confine of his village, and he got leishmaniasis. Parasitologically confirmed. I saw the Donovan bodies there with my eyes. How? Because there's a Bangladeshi got married to the orang asli and lived there. And we have phlebotomists around to help the spread. What about the multi-drug resistant malaria? What about multi-drug resistant TB? And we have an estimated 4 million unregistered migrants in this country. That is the nature of the health security issues that we are facing. And finally, I would like to take this opportunity to congratulate Professor Iwan Lim, the Deputy Dean of Research Medical Faculty of ST Malaya, and her active members for her outstanding work in intestinal helminthiasis, which is in fact another much neglected tropical disease. She is recently listed as one of the science star of East Asia by Nature. Only it's still hot in press. So with 2 international accolades, Dr. Nasni, who won the award from WHO, and Prof. Iwan, recognition by Nature. So tropical medicine is still very much alive in this country. And interestingly, the 2 areas in these 2 disciplines of tropical medicines are the most unpopular discipline, worms and maggot. During her inaugural lecture as Fellow of Academy of Science entitled Debunking the Myth about Gut Worms by Unlocking the Secrets of Gut Microbiota, Prof. Iwan has described a new frontier in understanding the relationship between us human and our coexistence with the worm. Who knows, one day, because of their team's effort, we might be swallowing capsules containing eggs of Ascaris lumbricoides as a treatment to inflammatory bowel disease. With that, ladies and gentlemen, I thank you for your attention.
Thank you, Professor Datuk, for your insights to the successful stories in eliminating tropical disease, the present issues we are facing now, and the need to be prepared in facing emerging diseases in the future. As Datuk Lokman mentioned, this issue needs a multi-stakeholder approach. Now is the time that relevant ministries, researchers from both private and public universities, local governments and NGOs need to take responsibilities in solving the problem. And it's high time we work together instead of working in silo. So with that, I open the floor for questions. Okay. So we now will proceed to the panel discussion. So I'll invite all the panelists.
Thank you, Associate Professor Dr. Siti and Datuk Lokman. We will now have a panel discussion with today's speakers. I would like to invite Dr. Rabindra, Prof. Pratap, and Datuk Lokman to have a seat in front. The discussion will be moderated by Professor Dr. Victor Lim, Pro Vice Chancellor, Institutional Advancement, IMU.
Thank you very much, Madam Chairperson, or Madam MC. Well, first of all, thank you very much for inviting me to moderate this session. Now, this session is an interactive session, and this is where the audience can and are encouraged to interact with the experts in the form of Prof. Pratap, Dr. Rabindra, and Professor Datuk Lokman. Now, we've gone a bit high-tech today, and you can actually post your questions online. Yeah? And I'm supposed to be holding this little tablet, and your questions are going to appear on the tablet. However, if technology doesn't work, just put up your hand and ask your question, okay? And then that will actually save us a lot of time. So while you're thinking of your questions, perhaps we can start off by maybe getting some views from our distinguished panel. Maybe I can start by being a little bit provocative. It has been said that the term tropical medicine may be a bit of a misnomer, because when you use the word tropical, you're really thinking about climate. Obviously, climate does contribute to the prevalence of the infections and other diseases that we are talking about. But there are also a lot of other factors that are involved in maintaining these diseases. Well, some of the tropical diseases are also called tropical disease, like cholera or typhoid or even malaria, used to actually be quite rife in Europe. But they have managed to bring them under control, primarily through better sanitation, public health, maybe affluence and things like that. So there is some people who say that maybe the term tropical medicine should perhaps be replaced by geographical medicine or even medicine of the developing world. And it's not so much that these diseases are rampant in the tropics, but because most of the countries in the developing world just also happen to be in the tropics. But then this has got, gives us certain important implications that if you really want to control these diseases, then you have to look at it, as mentioned earlier, from a much wider perspective, because there are many, many other dimensions apart from medicine and health that actually will influence our success or otherwise in controlling these diseases. So you've got to look at maybe the social, economic, and even the political aspects. Because we know that many countries where such diseases are prevalent are not exactly really poor countries. It's just that the wealth is very unevenly distributed. So you got a few people who are extremely rich, and then of course the vast majority live in abject poverty. So it's more the political system and maybe even corruption that is driving the prevalence of these diseases. So maybe I can ask some comments in response to what I've just said.
Very thought-provoking. Yes and no, for two reasons. Why no and why yes? Tropical medicine is still predominantly a challenge for the tropics, but it's a challenge for the tropics for two reasons. As I tried to explain, and many of the other speakers also alluded to the same fact, these diseases are largely prevalent in the tropics because of the climatic and ecological conditions in the tropics are conducive to the survival of the parasites or their vectors or their intermediate hosts. And so it is intrinsically more difficult to get rid of them than in countries with countries to the north or the south of the hemispheres, where you have a very warm summer season and then relatively cold seasons when the vectors disappear. So even if you take the case of malaria in Europe, it's easier to interrupt the cycles. And as Prof. Pratap mentioned, the extrinsic incubation phases are much longer, and so interrupting transmission is much easier. But the other reason why we still see the problem in the tropical countries is the huge differences in access to services. So yes, we have economically grown. We are growing in this part of the world at 6 to 9% a year, but still we have huge population groups that don't have access to basic services. And it's recognizing this that WHO is calling for universal access to healthcare as a solution. Because although as economies we've grown, the wealth distribution, as you mentioned, Prof, is not equal. And so we still have populations that are remaining at risk to these conditions simply because they don't have access to basic health services, whether it's water, sanitation, or to diagnostics and treatment services. So we are never going to get rid of these diseases if we just focus on the medicine. It needs to be a multi-sectoral approach addressing all of these challenges, but the primary focus should be improving universal healthcare, and that includes actually access to physicians, trained clinicians who are capable of diagnosing and managing these conditions. I'll stop there.
Yes. So I think that is going to be a very important point, that what you have mentioned, that there are many diseases that what we see in the tropics also see in the temperate zone. For example, if you look at London in 1854, you see 100,000 died. Okay, and if you go to the Broad Street today in London, you still see the John Snow pump still there. Okay, if it is in Bangkok, it would have been removed. But luckily that it is in London. What I would like to say that we see that in tropics, in addition to the, as you mentioned, geographical or the tropical things, tropical areas, as I mentioned, of course it is the climate, the ecology is very important. For example, you see that falciparum malaria transmit in the areas where the temperature is, if it is below 20 degrees Celsius, extrinsic incubation period, okay, will be very long, forever. Parasite not going to develop. Vivax is 16 degrees Celsius. So it relates. And in the tropics, usually the life expectancy of the children in the tropics 50 years ago at that time is 12 years or to 15 years lower than the temperate zone. And then we also see that there is a transition. What they have, we also now having. So it is going to be something that there is an epidemiologic transition. When the economy improves, hygiene and sanitation improves, we also bring in the diseases that we never had before. Okay? For example, the NCDs. And then with the disruptive forces, which is very clear that demographic urbanization demographic transition, and then there are so many things that the lifestyle changes. So also bring in the diseases that we never had before. That's why we have double burden, triple burden of the issues. So now, what is the cause of death in the tropics? It may not be tropical diseases anymore. It is the non-communicable disease, heart disease. In Thailand, it is the accidents, injuries is number one. Okay, in some countries, maybe homicide. Okay, so the cell injuries and also the accidental injuries. Now we are facing with the third generation disease. After the NCD is the mental health issue, drug abuse, okay, violence, and other health issue. Now WHO going to put game addicts, okay, as in the ICD-11, right or not? So now, so is it only in the temperate or in the tropics? It's everywhere. But what happened is that we are in the state that so therefore I'm just saying that whatever you call, but we see that this is still inherent in this area. And then one study very clear published in Nature, if you look 6 years ago, that they look at the pathogens, all pathogens in the world, 90% are concentrated near the equatorial area. And then less and less as you move upward, okay, upward or downward, but it is concentrated, 90% of the world pathogens. Okay, let's say I'm talking about the infectious pathogen. Now we have 2,841 pathogens that are known today. It may be changed already tomorrow. But I'm just saying that these 90% of that will be concentrated among the equatorial area.
Okay, so questions are now coming in thick and fast. So technology is working. So the first question is for Professor Lokman. During the dilemma of Dengvaxia, did MOH achieve unanimous agreement not to register Dengvaxia?
Unanimous agreement mean among the officials of the Ministry of Health? I'm not sure about the...
I'm not sure. I mean, I'm just reading. I suppose unanimous agreement...
As I was saying, I was describing this now. We receive a lot of pressure from professional bodies. I mean, at the policy level, Ministry of Health. I mean, my argument about why we should not be registering yet the vaccine was very clear. I mean, the minister buy my argument and the reasoning that... But of course, in public health policies, there's so many other factors that influence this kind of decision. And that's what I'm trying to describe to you. The pressure that being put upon the ministries to register the vaccine. Because remember, we are at the background of a very severe outbreak in 2015. 120,000 cases and almost 200 dengue deaths. And suddenly the next year, 2016, Sanofi said, yeah, we have the vaccine now. So the pressure for us to register is tremendous, really tremendous. Even the question was even asked by the Prime Minister during the Cabinet Minister. Even the Minister is also having pressure from their Cabinet members about why we are not registering. So in terms of unanimous decision at the ministry level, I would say that yes, we have quite a solid, firm agreement on the principle of that decision. But as you said, even among the professional body outside Ministry of Health, we are not getting that kind of understanding. And this leads to the question that sometimes, even professional bodies, I question some of these professional bodies because of the vested interest. As well as remember that many of these professional bodies are supported by the pharmaceutical industries in their activities. So we have we have to be very clear about all these issues when developing a national. That's why I said, if you go back to the principle of evidence-based public policies, based on good science, based on integrity, you should not be derailed. But you have to be very strong. And that's what my conviction is. And I'm glad that we have made that decision. You just imagine if we register the vaccine and start using it, like what's happening in Philippines now. who is going to be held responsible among those vaccinated that has been vaccinated? Who's going to be responsible? Sanofi? Ministry of Health, Department of Health, Philippines? It's a big issue. Now people, they are suing each other. At least we have avoided that part in this country.
Oh, thank you, Prof. Lokman. I think you mentioned the word integrity. I think that's very important because I think it's not just, I'm not talking about Malaysia, but all over the world, sometimes there's an unholy alliance between professional bodies and industry. I'll leave it at that. Now, another question for Prof. Lokman again. Is IMR going in the right direction? During your year at MOH, your years, is there any effort to better support the roles of IMR in tropical medicine research? In other words, is it going in the right direction in its current form? I'll put you on the spot.
I like what CP was saying. As long as you continue to be scientific, purely focusing on science, leave alone the politics, then you will go far. To me, I've spoken to every minister that have served the ministry ever since I was in the IMR. If I'm not mistaken, 4 ministers. Asking them, begging them to get back IMR to the original governance. IMR started as a statutory body, not a department. IMR started as a statutory body. IMR has their own budget right from the treasury, not under the Ministry of Health. IMR has the power to hire and fire at that time. I remember asking Datuk Lim Tiong Wah, the lead director of IMR, when we were in Geneva one day, where do you see the problem with IMR? He said it's a problem of governance. The decline started when IMR was taken over as a department in the Ministry of Health. That's where you lost control of the direction of IMR. That's my personal view. I've made it clear, I've opened it, I've talked to the minister, even to the last minister, Subramaniam. I hope I will have another opportunity to be the new minister, and I will say the same thing. I'll be governed by on themselves, on the science of it. When you put under the department, then you have problem with priorities. When budget come low, research will be the last. That's it. And you suffer.
Oh, so, difficult to, well, sometimes it's not actually, the problem is with politics. The problem is with politicians. Okay, next question. Again for Prof. Lokman. You're really going to earn your lunch. Now this is on the impact of Nolasai. Although no human-to-human transmission has been proven, but humans are still dying from infection. And yet, they say that the public will be informed that our country is free from malaria, which means that you do not need to worry that you will get malaria when you travel into the jungle. What is your comment on this issue?
Well, for human malaria, I mean, the risk for Nolasai is there, obviously, even in Peninsular Malaysia. In fact, most of the reported Nolasai infection in Peninsula is related to some of this activity in the interior, in the forest, where you have the contacts with the animal host and the mosquito that carries the parasite. So the risk is there. I think even in the Ministry of Health advisory, that when you are involved in activities in those regions, in this part of the country, you must take precaution. We are not saying that there's no risk at all. There's still risk of getting infection with the parasite and dying because of it if you are late in getting the diagnosis. We have few fatalities because delay in diagnosis. Because somehow, that's another problem. Many of the clinician, physician in a major hospital are already forgotten about malaria. When a person comes down with high fever, chills and rigor, the last thing they think on the infection is caused by malaria. So only when the patient into a very critical stage that when they look back at the blood, then only they realize that the patient's having malaria. That's another big issue that maybe we need to also look into. I mean, the awareness of our clinicians on some of this infection.
If I may add to that, Navalesi being possibly a more recent form of malaria affecting humans, it tends to develop faster in humans. That's what is recently being found out, primarily in research done in Sabah. And severe malaria develops at lower parasitemias than falciparum. And these two factors to combine together with late diagnosis actually is contributing to the deaths that we are seeing in Navalesi. It's important to get that messaging correct, that it's not a benign condition, because there is a mistaken belief that Navalesi is relatively benign. It is not. And so, while recognizing that the human malarias are declining, we still have to find ways of reducing actually the impact of the Navalesi malaria and its actual incidence. It's easier said than done because we are encroaching on the vector space. We are clearing jungles and moving into the Anopheles crescens or leucospherus areas, and hence humans are getting increasingly exposed to bites by mosquitoes carrying the parasite. So this is very difficult to actually address.
Thank you. The next question is for both Datuk Lokman and Dr. Ravi. What is your comment on the need for quantifying the exact burden of any neglected disease in previously unexplored provinces within endemic regions?
Well, if you don't know what you're dealing with or the scale of your problem, it's very difficult to actually have a comprehensive strategy to address the challenge. So be it neglected tropical disease or any disease for that matter, you need to know who is affected, how many people are affected to have a comprehensive approach. Otherwise, you're not going to deal with it effectively at a public health level. You may be able to deal with individual patients, but if you want a public health solution, you need to have a clear understanding of the epidemiology and the burden of the problem in the community.
So I think the person who asked this question says that, this is in relation to developing low cost but good diagnostic tests for screening. So obviously this is an area that we need to really look into.
In fact, we do encourage that, and now we are looking at encouraging not the screening for one disease, but using multiplex systems to screen for maybe 10, 15 diseases. And I must mention, I was encouraged that I saw one of the posters out there mentioning a multiplex approach, which is what we are advocating, because you can diagnose for the presence of multiple diseases with a very small quantity of blood using that technology.
Okay. The next question again about Plasmodium knowlesi. It says that, it is now a major problem, but if we continue to say it's not a human malaria and that malaria is being eliminated, will that not affect our ability to secure funding for research into this area? General, not...
I mean, people have the misconception that it's largely a Malaysian problem. It's not largely a Malaysian problem. Malaysia has quantified the burden of the problem. Increasingly, we are becoming aware that Navalesi is prevalent in Indonesia, in Thailand, in Vietnam. The issue is that to confirm Navalesi, you need to have molecular diagnostics. That's the availability of the current tools. And so many other countries don't actually have a clear idea of the burden of the problem they're facing. So what we are saying is that yes, our primary focus is getting rid of human malarias, but at the same time we need to work towards reducing the burden of the zoonotic malaria, particularly in Malaysia. And so research will play a fundamental role because, as I mentioned, the vectors, you have now isolated the vectors, but their bionomics is different to the traditional malaria vectors, and so we don't have effective tools that target those vectors. It's imperative that we develop those tools and evaluate them and start using them if we want to actually change the dynamic. In the same way with the diagnostics and the treatments.
I think one way is to address about this issue of funding is to maybe to reposition issues like knowledge as a travel medicine issues. I mean, then when we talk about travel medicine issues, then you have a big client out there in the developed nation because they love to travel, so they probably want to invest a lot more on the and that kind of thing. So because when we talk about elimination, we're talking about the program per se. Why? I mean, in terms of certifying whether a country has achieved the elimination status or not. That was the issue when we were discussing about whether simian malaria will impact on the eliminations of malaria in terms with regard to the issue of certifying the member state status on that program.
Just out of curiosity, you know, in the good old days, when we go into the jungle, we take malarial prophylaxis, but not against Nolisai specifically. Now, if you do the same thing now, would you be protected against Nolisai?
I mean, Nolisai is very responsive to most of the anti-malaria drugs. In fact, it's still chloroquine, which is no more effective against falciparum, for example, are still very useful for Nolisai. But I don't know, I mean, if you develop the travel medicine thing, if you can actually give more advisory regard to the risk that when they are facing, the risk that they're taking when they do certain activities, I think that will much be better. Because like for myself, for example, I don't take prophylaxis, but at least I know the risk. So whenever you come down with some sign symptom, you quickly go. I mean, but the problem is, in this country in particular, travel medicine is still not where it's supposed to be. I mean, something probably in an area that I think we need to develop further with regard to this particular issue.
May I add on this?
Yes.
On Nolisai, in fact, Nolisai, you can see here in our hospital, right in Bangkok, okay, we have diagnosed several cases. The lady who diagnosed Nolisai is sitting there, okay, using the PCR in her lab. Okay, at least I think in Thailand, officially we reported more than 30 cases. But in our hospital also we have been diagnosing. So it depends on what is the magnitude of the problem. Okay, but we are seeing Nolisai. Now, when you are thinking about the treatment, in fact, now they are sensitive, very sensitive. If you have a standby drug, like you're using for, let's say, coartem or let's say artesunate and artemisinin derivatives, okay, you can take that because we have a program for our soldiers who are at the front line. They have a rapid diagnostic test, and then you put the drugs because you cannot bring them down. Okay, it takes so many. So they diagnose whatever the malaria positive. Okay, let's say all malaria species, and then you can treat it. So, but for Nolisai, I think we don't have that RDT yet. But I'm just saying that they are very sensitive. It's no problem at all for the drugs that you are taking for other species.
Thank you. Yes.
May I look at it from another perspective? Because we talked about the fact that we don't have funding for research. And if this is a travel problem, and many of the other tropical diseases are actually travel problems, and you have a global health security risk. Now, if we look at the example of Korea, which has, I believe it's 1 won tax on every air ticket. If you introduce something like that, or the Philippines has what they call the SIM tax, which gives money to deal with health. So if you look at the volume of people traveling and you have a 1 ringgit tax which goes to medical research to address tropical disease problems, you suddenly have a lot of money to actually address the challenge. And it's actually not a big burden on everybody. So I think we as a community have to think of novel ways of how do we address this challenge in a holistic manner rather than looking at piecemeal issues which we will never be able to fund and address if we do.
Thank you. Now, can I check with the organizers? 1 more minute. Oh, 5 more minutes. Okay, because I don't want to deprive people of their lunch. Okay, now, next question for Prof. Lokman. How can we protect the public from importation of diseases? What are the measures currently in place, I suppose, in Malaysia?
Well, as I said, I mean, the discipline of travel medicine is still not very well developed in this country. We don't have a very specific advisory platform where the public can actually, if you look even in our Ministry of Health website, for example, we don't have much written about advisories to Malaysian moving, going away to abroad in areas where at risk of acquiring certain specific infection. So I mean, the only way to actually prevent the introduction for Malaysian themselves is actually to provide a good advisory about the risks that they are facing. And that's why the Center for Disease Control, CDC Malaysia, that we have been talking about, because these are the roles that we have been talking about, developing and enhancing. Maybe the academic universities might want to look into and start developing into this area. I know that IMU has been talking about travel medicine for quite some time. There's some initiative by our partner university to develop into it. So probably IMU would like to take it seriously in developing this thing. On the part of foreigner bringing in their problems, we really need a very strong political will to address the problems of migrant workers. There's no other way unless you control the migration of the movement of people across border. You need a very strong border control program policies. But looking at what's happening in this country, I do not know. Our borders are very porous. It's not only an issue of health, but even in terms of trade. There are so many smuggled goods that come into the country. I know of this because we're having the challenge of tobacco control, for example. There's a huge volumes of illicit tobacco coming into the country because our borders are very porous. So until and unless we address the problems of migration at the national policy levels, we are going to continue to live and having the risk of importing all those conditions that were listed in my second last slide.
Thank you. Now, time is really catching on. I know that there are some more questions, but I don't think we have time. But I'll give the privilege of the last question to our Professor Emeritus, Datuk CP.
Thank you, Mr. Chairman. I appreciate that. I thought I will ask a very broad question, not a question, suggestion. First of all, I'd like to congratulate all the brilliant speakers. I think they all gave a fantastic job of bringing us up to date on all aspects of tropical diseases. The question I have is, what is the future in terms of tropical medicine as a science in this part of the world? And IMU is part of it, and many other universities and so on. And I think, Professor Pratap, you brought up in your presentation the idea of human resource development. And I'm afraid that the number of students today, as a teacher I can say, interested in parasitology and tropical medicine is dwindling. We are lucky in Malaysia that we still have a department of parasitology, perhaps some of them are here, and 1 or 2 other universities. But in general, it has been put together, for instance, under communicable diseases, and we lose our sight as to where we are going. And for instance, in a country like India, I was there last week for a meeting, there is hardly even one department of parasitology. It's all under communicable diseases, and very little attention is paid towards diseases of poverty. So that's one thing. And the other thing you brought up was, which are the universities in this region which will be able to continue contributing? Because I'm afraid that this is not the end story. It is the beginning of the end, probably, anyway. The other thing is, we discussed at length the need to bring veterinary and human medicine together. And I think One Health approach becomes very critical now, particularly in terms of zoonotic infections. That has been biggest problem in this area. And from Abey's point of view, in the Pacific Islands, for instance, many of us here in Malaysia don't even know these islands and people exist. But there they are. There are 25 countries in the Pacific Island countries which are all having their own problems, not only with dengue, but maybe a few other infections as well. So the question of tropical medicine in this part of the world, to me at least, will remain very, very relevant for another 10, 20 years, hopefully. And I hope our universities and colleges and others will contribute, including the IMR. Thank you very much.
Thank you. Responses?
So thank you for the question. We have thought about this. We even have the expert from our partners, tropical medicine schools like Liverpool, okay, and other schools to say that what is going to be in the next 10 years? Are we going to survive, or we have to change to some faculty of something? Because as you can see, the trend, the epidemiologic transition of the diseases, but as we see that now we are transforming. For example, as maybe the Datuk Lokman already mentioned, and now we have opened up the traveler medicine. Okay, this is the residency program, and also the traveler medicine that we include, try to include more tropical medicine in them, because the clinician would be interested to know, because the people travel. They travel to Africa, travel to many areas where tropical diseases are still endemic. So therefore, we put the tropical medicine in those areas, okay? And as you also mentioned that now we are trying to, is dwindling also the entomologist. We are very surprised that our PhD student, very few now select entomology as their area of expertise, which is very shocking, because entomologists are less and less every day, okay, even in Thailand. And then as you mentioned in the beginning, that now we are talking about the global health security agenda. Now for all the countries, we have international health regulations. I just came back from a meeting of the both region, Western Pacific and Zero, sitting together, and then try to look at the preparedness, okay, how the country going to get prepared and response to something that is going to be emerging disease, okay. You cannot stop migration. It's going to be impossible. But if the event happen, how are we going to respond? That's why WHO have a system they call JEE, that is Joint External Evaluation. They come to the country, they already evaluated Malaysia, requested, and Malaysia passed very well, okay, that if the things happen, how Malaysia is going to respond, and then with the international health regulation system. And then as you said that, now we have to be more proactive. We have to, that's why all the departments in Faculty of Tropical Medicine, we still maintain Department of Helminthology, Protozoology. So therefore, now we are looking at the people who have been transplanted, and then you get protozoa infections. So the surgeon, the other groups of the people are interested in parasitology, okay? And also looking at the emerging animal, the One Health one that you mentioned, so that we are talking about the animal parasite, how it's going to cross the species barrier, okay, into humans. So therefore, in that way, but in the beginning, at some time, we were thinking that our future would be very bleak, but it's not going to be like that. I think it's going to be for some time.
Thank you, Dr. Rabi.
So if I may add, I think it's partly our responsibility to create the career prospects, and still there's a long way to go, as Dr. Lokman mentioned, and you've seen the awards of Nazni and Professor Yvonne internationally being recognized. So still there is a lot of potential and a lot of work to be done, but we need to make the sciences relevant to the younger generations. So if you look at the global vector control response, we are not any longer talking of entomology or medical entomology. We are talking of public health entomology as a science. So you need to make it more attractive to the younger generations. And then we also need to be cognizant of the fact that our world is becoming smaller and smaller, and so we are seeing exotic conditions that were never seen in our countries. So we are seeing, for example, human African trypanosomiasis, or sleeping sickness in this part of the world. We are seeing Chagas, diseases that we never saw because our world is becoming smaller, people are traveling more, and you can travel in much shorter times, which means we need to equip our clinicians and our physicians with the capacities to detect and manage those conditions, and that's what we are seeing. When we talk of, like I mentioned, China has 0 indigenous malarias, but because of the huge number of Chinese workers in Africa, they're seeing more than 3,000 imported malaria cases. So these problems are not going to go away from us, and we need to have the capacity to manage them in the future.
Thank you. Dato' Lokman, any last words?
Well, for the Malaysian context, I think parasitology is still surviving. I mean, at least our premier public university, they still maintain the Department of Parasitology. IMA still has maintained the division of parasitology, and we just hope that this is been sustained. And I hope in IMU too, Prof is retiring, a few other parasitologists is retiring, so I hope they will get a new parasitologist to take over, not just to carry off. But in terms of in the Ministry of Health itself, I think the emphasis on allied health sciences in the provision of health care is very clear, very good. Even, for example, entomologists, I think we have Malaysia has the largest number of servicing entomologists in the government service. We have more than 150 entomologists serving the whole country, and I hope politics doesn't get into it, that these people will be shunned off later on in their career movement. So I think there's a real role of tropical medicine and parasitology in the future that I think we need to continue to provide resources for in this particular discipline. Thank you very much.
So, thank you. So, all it remains for me to do is to thank all our experts, Professor Pratap, Dr. Rabindra, and Datuk Lokman, for all their wise words. And of course, to thank the audience for, actively participating in this session. So, thank you very much.
Thank you, Prof. Victor, and all the panelists. If the panelists could please remain in front. Before we move to the prize presentation for the poster competition winners, I would like to invite Professor Chu Wan Loy, Dean of Postgraduate Studies, IMU, to present a token of appreciation to each speaker. To Dr. Rabindra. Prof. Pratap. And finally to Datuk Lokman. Thank you, Prof. Chu. Thank you all the speakers, and thank you, Prof. Victor. We will now announce the winners of the poster competition. I would like to invite Emeritus Professor Mark to the front to present the prizes to the winners. In third place, is Mr. Muhammad Ridwan Muhammad Ali from Uniscience Malaysia for his poster titled Novel Multiplex Real-Time PCR for Simultaneous Detection of Leptospira, Burkholderia pseudomalae, Salmonella and Plasmodium DNA. In second place, Miss Amelia Yap Zheng Hua from University Malaya for her poster titled The V1016G point mutation, the key mutation in the voltage-gated sodium channel VSSC gene of pyrethroid-resistant Aedes aegypti in Indonesia. And in first place, Mr. Wong Yi Hao from IMU for his poster titled Effect of Mouse Passage on the Virulence of Axenically Cultivated Acanthamoeba castellanil, a genome-wide transcriptomic analysis. Thank you, Prof. Mark, and congratulations to all the winners. I would now like to invite Associate Professor Dr. Siti Nurshina, MSPTM President, to present a certificate of recognition and a plaque to Emeritus Professor Mark Junwa. Emeritus Professor Mark was the past director of the Institute for Medical Research Kuala Lumpur. After his retirement, he joined UPM as a professor and subsequently IMU as the Dean of School of Postgraduate Studies. Prof. Mark was a past president of the MSPTM and the founder of the Tropical Biomedicine Journal, where he served as the editor for the first 3 years. Prof. Mark is also the recipient of the Society's Sandosham Gold Medal and the prestigious Merdeka Award in 2011. The Society is very proud to recognize Prof. Mark for his excellent contributions and achievements in the field of parasitology and tropical medicine. Thank you, Dr. Siti. And if Prof. Mark could please stay on for another prize, another token of appreciation, I would like to invite Professor Dr. Victor Lim. Is he here? Datuk Lokman, Director of Institute for Research and Medical Research and Innovation of IMU, to present a token of appreciation to Emeritus Professor Mark on behalf of the IMU. Thank you, Prof. Victor. I would now like to invite Professor Bharathalingam Senior for the presentation of a token of appreciation from the MSPTM. Sorry, Prof. Mark, could you please be up in front to present the token? Professor Senior was professor of the Department of Parasitology, Faculty of Medicine, University of Malaya. Prof. Senior was the past president of the MSPTM and was also a recipient of the Sandosham Gold Medal. Furthermore, he was the past editor of Tropical Biomedicine from 2015 to April 2018. With that, the MSPTM is pleased to acknowledge Prof. Senior's contributions and services to the Society as well as the journal. Prof. Mark, please stay on. There's one more prize. Thank you, Prof. Senior. We will now have the presentation of life membership of the MSPTM to Mr. John Jeffrey. I would like to invite Mr. John Jeffrey to the front. Mr. John Jeffrey was a long-time council member and past vice president of MSPTM. He was the assistant editor of Tropical Biomedicine and a past recipient of the Sandosham Gold Medal. Before retiring, he served at UKM and IMR and had published more than 200 papers to date. With that being mentioned, the Society is pleased to confer a life membership status to Mr. John Jeffrey. Thank you, Prof. Ma and Mr. Jeffrey. I would now like to invite Professor Datuk Dr. Lokman to give a note of thanks.
All right, ladies and gentlemen, we are now come to the end of our special MSPTM mid-year seminar on tropical medicine, specially organized jointly by MSPTM and IMU in recognition of the contribution made by Professor Emeritus Mark Junwa. In this regard, I would like to thank Dr. Rabindra and the WHO Western Pacific Office for the support and participation in this seminar. Special thanks to my good friend, Professor Pratap, and his colleague from the Faculty of Tropical Medicine, Mahidol Universities, for coming all the way from Bangkok and support our seminar today. And I sincerely hope to see a closer cooperation and collaboration between IMU, MSPTM, WHO, and CIVA-TropMed in teaching, learning, and research in tropical medicine. I would also like to thank the organizing committee, co-jointly chaired between Prof. Chu and Prof. Sharina of MSPTM for the work well done. And last but not least, to all of you, participants of this seminar, without whom the seminar will be nothing. Thank you very much for your time. Have a safe journey back home. Thank you very much.